Good morning, guys. Hello. Am I audible to you? Am I audible and visible? You can see that there are lots of online, lots of people who have joined online also. So if you can see me and if you can hear me loud and clear, please give a thumbs up in the chat box so that I can. Okay, okay. Thank you, Sandra. Okay. So there are no technical issues, right? So shall we start? Okay, I think few more people are joining in. We'll give them few minutes to join. Okay. Okay, how was the exam today? Good. So I want this session to be an interactive one. So whenever we discuss some questions, so I want you, all of you guys to type in your answers who have all joined as online. So Sandra is asking if I'll provide the PDF. Surely I'll send you the annotated PDF data. Abhishek is saying that the exam was little easy. So I had focused more on the previous year questions. So almost 50% of the questions were from the previous year questions itself. Abra, good morning. Yeah. I'm waiting for a few minutes so that everyone can join. Abhilash, I'm very fine. Thank you. Atul, Sugumana, good morning. So how are your preparations going in full speed? Abhishek is saying that there is pressure increasing every day. There's no need to be under pressure, man. Be cool. Unless you keep your head cool and you approach these things with a level head, it's going to be difficult. I know that it is a very challenging situation. This is a life defining moment for you. But even then, you have to uh, face everything with a level head. Otherwise, you won't be able to succeed. So keep calm, continue studying. Some days are not that much productive. That is true for everyone, man. That is how it is. So sometimes you study for 16, 18 hours a day. Sometimes you can study only for 2 hours. That is how it is for everyone. 3 years internship. Yeah. Even though the circular has come out, there is no clarity on that. I think we are all protesting against it. Let's see what the outcome is. Even the circular is very, very ambiguous, isn't it? It is written 2 to 3 years. What kind of circular is that? I mean, they also have no idea what to do. So probably they will go through it again and probably they will revise it. Good morning, Jenny. Good morning, Umesh. So one thing I would like to tell you is that don't think about the internship right now. Okay. You don't get distracted by all those things. That is the first thing. Internship जब आएगा तो देखा जाएगा. अभी से उसके लिए टेंशन नहीं लेना है. ठीक है. So if you are spending more time thinking about those kinds of things, then it's going to be difficult to study. So focus on what is at hand right now. The first step is to clear your FMG exam. So the first step is to get that 150 marks. Once that is done, rest is easy. No, then rest we'll see what we can do. So first, your focus should be entirely on clearing your FMG exam. Rest are all distractions. Don't think about it at all. Okay, don't discuss these things with your parents. There is no need for that. First, let's clear our FMG exam. Then we'll think about all the rest of those things. Agila, good morning. Okay, I think we can slowly start our class. So welcome all for our test and discussion. I hope the exam was easy. I had focused mainly on the previous year questions. 50% were directly previous year questions. Only the wordings were changed a little bit. 80 to 90% of the questions were from the previous year topics. And 10% I would say from very important topics that I felt could be asked this time. Okay. So first, let me introduce myself. If you don't know me or if you have never attended my classes, I am Dr. Rohit Daniel. I am currently working as a consultant orthopedic surgeon in Trivandrum. I am a faculty in orthopedics in doc tutorials, as well as I conducted online classes for ARISE as well. Few of you at least would have attended my online classes. So let's start with the first question. Okay. So a 30-year-old male sustained injury to his left lower limb in an RTA. X-ray showed a fracture of the femur. On examination, there is a wound of 6 centimeters and there is no soft tissue loss. However, the femoral artery is injured. What is the Gustello-Anderson grade? Can anyone tell me the answer here? This should be an interactive session. Okay. You guys should type in your answers. What is the Gustello-Anderson grade? This is type 3C, type 3C. Now, what is this question based on? The question is on a very good Abra. This is D grade 3C. Why? See, this is a question on a fracture associated with a wound. What do you call these fractures? Open fractures. These are your open fractures. And what are open fractures? A fracture with a wound like this, where the fracture hematoma is communicating with the outside. Now, open fractures are classified based on the Gustello-Anderson classification. Very, very important for your exam. The main point here is classification based on the size of the wound. Okay. If the size of the wound is less than 1 centimeter, it is type 1. If it is between 1 to 10 centimeters, it is grade 2. And if it is more than 10 centimeters, it is 3. Now, type 3 is again classified into 3 types. 3A is where you have a long wound, but you can easily put stitches on top of it and close the wound. So it is not that much difficult to manage. But in type 3B, you cannot put stitches. Why? Because a large part of the wound or large part of the skin and the muscle are completely lost. Okay. So you cannot put stitches on it. So what you'll have to do is you'll have to take a piece of muscle and soft tissue from some other place and transfer it onto the wound. This is what we call as flap surgery. You have to do a flap surgery to close the wound. That is your type 3B. And type 3C is when there is a major vessel injury. So what happens when there is a major vessel injury? The blood supply to the limb is completely lost. And if you are not doing anything, what will happen? The limb will be completely gangrenous and you will have to do an amputation. So this is the most dangerous type of open fracture. This is type 3C. The important thing to note here is that type 3C, you don't have to worry about the size of the wound. Okay, even if the size is less than 10 centimeter, but there is a vessel injury, a major vessel injury, then you will have to call it a type 3C injury. Okay, so let's go back to our question. What is the size of the wound? 6 centimeter. But there is femoral artery injury, isn't it? Femoral artery is injured. It is a major vessel that is injured. So it is limb threatening. So obviously you'll have to call it a type 3C, even though the size is 6 centimeters. So remember, if there is a vessel injury, forget about the size of the wound. Even if it is 1 centimeter, you'll have to call it a type 3C injury. Okay. So that is your first question. Shall we go to the second question? Bone loss in Hill-Sachs lesion is seen in which part of the humeral head? What is the answer? Very, very simple, straightforward question, isn't it? It is seen in the Abra again, good. It is seen in posterolateral aspect of humeral head. Correct, Abhilash. Very good. It is posterolateral. What is this Hill-Sachs lesion? It is a defect that is seen in recurrent dislocation of shoulder, isn't it? Recurrent dislocation of shoulder. What is recurrent dislocation? Where what happens is that when you dislocate the shoulder, sometimes some injuries happen to the shoulder, and whenever, because of those injuries, the shoulder will get weakened and the patient will get recurrent episodes of dislocations. That is your recurrent dislocation of shoulder. And there are two types of injuries that are commonly associated with recurrent dislocation. One is your Hill-Sachs lesion, okay, where there is a bone loss in the posterolateral aspect of the humeral head like this. So that is your Hill-Sachs. Second is something called as the Bankart lesion, isn't it? Bankart lesion. In Bankart lesion, there is loss of, or there is an injury to the glenoid labrum in the antero-inferior part. So there is glenoid labrum tear in the antero-inferior part. Okay, that is your Bankart lesion. Now tell me, which is more common, Hill-Sachs or Bankart? Can anyone tell me? Which is more common? Very good, Garima. Absolutely right. Bankart is the most common. Okay, this is an important MCQ. Bankart is the most common type of injury that you see in recurrent dislocation of your shoulder. Yes, Atul, Ginny, absolutely correct. It is the Bankart lesion. So next question, which nerve injury can occur in the fracture shown in the X-ray? Can you give me the answer? Yes, don't worry. As I told you, I'll send you the PDF. Don't worry. I'll send you the annotated notes. No, don't worry at all. Very good, Garima. Very good. Absolutely right. It is posterior introitious nerve. Very good. First of all, tell me what fracture is this? So if you see, this is an X-ray of the forearm, isn't it? X-ray of the forearm. And you can see two bones here. So how do you know which is radius and which is ulna? The easiest way is to think like this. You know that the radius is thicker where it is wider at the wrist, isn't it? So the bone which is wider at the wrist is your radius. And the bone which is thicker at the elbow is your ulna. So which bone is fractured? There is a fracture of the ulna. There is a fracture of the ulna in the proximal third. Proximal is upper third. Then is there something else? There is a radial head dislocation, isn't it? How do you know that radial head is dislocated? So normally, if you draw a line through the radius like this, it should pass through this structure, which is the capitulum. Capitulum of the humerus. That line should pass through the capitulum. If it is not passing through the capitulum, this means that the radial head is dislocated. Radial head is dislocated. Okay. So there is a fracture of the proximal third of ulna with radial head dislocation, which is your classical. Yes, absolutely correct, Atul. This is your Monteggia. This is the Monteggia fracture dislocation. Monteggia fracture. And which nerve is injured in Monteggia fracture? It is the posterior introitious nerve. Why? Because the posterior introitious nerve goes very close to the head and neck of radius like this. So what happens when the radial head dislocates? It will go and press against the posterior interosseous nerve, isn't it? And cause the posterior interosseous nerve to get damaged. Now the question is, can you tell me what is the clinical feature of posterior interosseous nerve injury? What will be the deformity that the patient presents with? Yes, very good. Finger drop, very good. There will be finger drop. So remember, radial nerve injury will produce a wrist drop. Posterior interosseous nerve injury will cause the finger drop. Only the fingers will be dropped like this. Okay. Remember this, finger drop, posterior interosseous nerve injury. Okay. Wrist drop is radial nerve. Next question. Very, very important. Previous year topic. All hip dislocations are very important for you. Every other year you get a question from this. A 20-year-old man presents to the emergency department with history of RTA. He complains of pain in his right hip. X-ray is there. What is the diagnosis? Very good, Hanan, Rahuma, absolutely correct. Adul, correct. This is posterior dislocation of hip. So please listen to me carefully. In order to identify the dislocation on an X-ray, the only thing you can rely on is the deformity. Okay? Always remember the deformity. What is the deformity in anterior dislocation of hip? This is something you have to know for your exam. You cannot go to the exam without knowing this. The deformity in anterior dislocation is flexion, abduction, external rotation. Posterior dislocation is flexion, adduction, and internal rotation. The thing you have to remember is this: abduction in anterior and adduction in posterior dislocation. Look at the femur in the right side. Is it adducted or abducted? Tell me. Is the femur adducted or abducted? Adducted, isn't it? The femur is adducted. So which dislocation is it? Posterior dislocation. That is the only thing you have to look. You look at the femur, look whether it is adducted or abducted. If it is abducted, anterior. If it is adducted, posterior dislocation. Understood? So I'll give you a table. This is a very, very important table. Don't worry, I'll give you the PDF. So this is the table that gives you the important points of the hip dislocations. Posterior dislocation, remember, is the most common type, and it usually occurs after RTA because of a dashboard injury. The deformity is what? Flexion, adduction, internal rotation. There will be shortening of the limb. And the nerve injury, this is also very important. Nerve injury seen in posterior dislocation of hip is sciatic nerve injury. Sciatic nerve injury, okay? In anterior dislocation, it is much more rarer. Usually occurs when someone falls from a height. Usually a construction worker working in top buildings, they fall down and they get an anterior dislocation. And the deformity is flexion, abduction, external rotation. And the nerve injury seen is femoral nerve. Okay. So this table you have to learn by heart for your exam. Okay. Very, very important. Now look at this X-ray and tell me what dislocation is this. Can anyone tell me the dislocation here? Yes, correct, isn't it? Can see that the femur is abducted. Femur is abducted, so it is anterior, isn't it? Very, very easy. You may look at the X-ray and say, oh my God, how can I diagnose this? But thing is very easy. Anterior dislocation, the femur is abducted. Posterior dislocation, it will be adducted. That is all. Now, can you identify this dislocation? This is not anterior or posterior dislocation. This is a very good, Ginny. Very good. Abhishek, Kajal, absolutely right. This is a central type of dislocation where you can see the femoral head is dislocated into the pelvic cavity, isn't it? So what happens here is that you have the femur here, the acetabulum here. Because of the magnitude, severe injury, the acetabulum completely shatters and the femur dislocates into the pelvis. So sometimes maybe they could ask this X-ray. Okay. Just remember this. It is very easy to remember. You can see the femur entering inside the pelvic cavity. That is your central dislocation. All right. So we'll move on. Very good, guys. Very good. This Ilizarro external fixator, isn't it? Absolutely correct. All of you are correct. Very easy question, isn't it? So you can see that for those who don't know, I'll tell you, you can see that there is an external fixation device that is put here, isn't it? The fixation device is outside the body. So this is an external fixation device and it is made of rings. So a ring external fixator is called as the Ilizarov fixator. Who discovered Ilizarov? Can anyone tell me? Most of you are studying in or studied in the various countries that are formed from USSR, isn't it? So this was discovered by a Russian scientist called Gavril Ilizarov. Okay, there is a place called Krugan in Russia. I think many of you may have heard about it. He is called as a magician of Krugan, because he discovered Ilizarov fixator. Okay, magician of Krugan is Gavril Ilizarov, who invented Ilizarov fixation. Next question. Again, a relatively easy question, I would say. A 10-year-old girl presents with pain in her left arm for the last 3 months. Her X-ray is given below. What is the diagnosis? Very good, very good. And why do you say that? I think Ginny, Mupin, Rahuma, all of you are clear, correct. Why do you say this? What is the classical X-ray finding given seen here? X-ray finding. Very good, very good. Fallen leaf sign. I'll explain. Okay. So those who did not get it correct, please listen to me carefully. Okay. So if you see, look at this humerus. Look at the humerus, and you can see a large lytic lesion here, isn't it? Is it in the epiphysis or metaphysis? Can you tell me? You have the physis here. This is in the metaphysis, correct. This is in the metaphysis. What else do you see? Inside the cyst, there is a small piece of bone lying inside, isn't it? There is a small piece of bone lying inside. And this is what is called as the fallen fragment sign. Fallen fragment sign. And this is the classical feature of simple bone cyst. Okay. So some people are again having doubt. Just by looking at the age, you can make a diagnosis. Can you tell me how? See, a 10-year-old girl. In a child less than 10 years, there are only 2 tumors that can occur. One is simple bone cyst. Second is Ewing's sarcoma. That is the only 2 tumors that can be seen within 10 years of age. Where the simple bone cysts come from? It comes from metaphysis, isn't it? Ewing's sarcoma comes from diaphysis. So this is a metaphyseal lesion in a 10-year-old child. That itself will give you a diagnosis of simple bone cyst, okay? But even if you don't know all those things, just by looking at the fallen fragment sign, remember fallen fragment sign is for simple bone cyst. I'll also tell you why this happens. So this is the humerus. You have the physis here. A large cyst forms like this. Because of the cyst, the bone will become weak, and a piece of bone will break off from the border like this, and the piece will fall inside. And this is what is called as what? What is called as the fallen fragment sign. Understood? So always remember fallen fragment sign, simple bone cyst. Okay. Other tumors are also coming in other questions. I will describe them later. Okay. Next question. A 20-year-old male presents with pain of the left hip and limping for the last 2 years. X-ray is given below. What is the diagnosis? Again, this is a previous year question, isn't it? What is the diagnosis? Yes, almost all of you are absolutely correct. This is fibrous dysplasia. Again, can you tell me the sign that you see here? Very good. Shepherd-Crook deformity. Correct. If you look closely, you will see that there is a lytic lesion here. And because of the lytic lesion, there is severe bending of the femur like this, isn't it? The femur is bent. And this bend in the femur looks like the stick that is used by shepherds in foreign countries. That is why this is called as the shepherd crook. Shepherd crook deformity. Shepherd crook deformity, which is classical of fibrous dysplasia. Fibrous dysplasia. Okay. This is a very, very commonly asked question. So remember, just by looking at the shape of the femur, you can make a diagnosis of your fibrous dysplasia. Okay. Next question. A 15-year-old boy presents with pain of his right leg and occasional fever for the last 6 weeks. X-ray shows a circumscribed lytic area in the proximal tibial metaphysis with surrounding sclerosis. What is the most probable diagnosis? This statement itself, well circumscribed lytic area in the proximal tibial metaphysis with surrounding sclerosis. Please learn that by heart. That is the definition of which condition? Yes, again, very good, very good. Almost all of you have got this correct. This is Brody's abscess. Brody's abscess, okay? This is Brody's abscess. Understood? So, just look at this. So, when you hear lytic area, please don't jump into the conclusion that it is probably a tumor, okay? So, some of you are confused with osteoid osteoma. Where does osteoid osteoma come? Is it from the epiphysis, metaphysis, or diaphysis? Very, very important point. Very good. It is from the diaphysis, okay? Osteoid osteoma also has sclerosis, but it arises from the diaphysis. So, this is from the metaphysis of proximal tibia, okay? So, this is the classical definition of your Brody's abscess. I'll tell you what happens here. So this is the tibia. You have the physis here. This is the epiphysis. This is the metaphysis. Okay. So what happens is that there is some infection in the metaphysis and there is pus formation. There is pus formation which is spreading. But the body will, what will the body do? Body will try and prevent the spread of pus by how? By forming new bone surrounding the pus like this. That is why you get the central pus area as a lytic area. So central, you have the pus which will appear on X-ray as a lytic area, and around it you have the sclerotic bone. Okay. So this is what happens in Brody's abscess. Can I ask you something? Is Brody's abscess acute osteomyelitis, chronic osteomyelitis, or something else? Tell me. Not acute. Not chronic. This is subacute osteomyelitis. Okay, subacute osteomyelitis, where osteomyelitis will be running for 2 weeks to 2 months. That is the definition of subacute osteomyelitis. That also keep in mind. Okay, it is not acute or chronic. Brody's abscess is subacute osteomyelitis. Please remember this definition. Okay, this is what is often asked in MCQs. Next question, which is not part of canaveral cardinal signs? Can anyone tell me? Very good, guys. Very good. Absolutely correct. This is pus pointing on skin, isn't it? So where do you use canaveral cardinal sign? We use it for finger flexor tenosynovitis. What is that? All our fingers have extensor tendon and flexor tendon. Sometimes there is inflammation and infection of the flexor tendons. Okay. And this is very difficult to diagnose by doing investigations, ultrasound, MRI, all these will not give you correct diagnosis. But just by using the canaveral cardinal signs, you can make the correct diagnosis of flexor tenosynovitis. Okay. So there are 4 points in canaveral cardinal signs. If a patient has flexor tenosynovitis in the finger, first the finger will be swollen. Then the finger will be bent like this. There will be flexion in the finger. The third point is that if you palpate on the tendon, it will be tender. And if you try and stretch the finger, there will be pain. So swelling, flexion of the finger, palpation will be tender, and extension will be painful. These are the 4 canaveral cardinal signs. And The point that is not seen is first pointing on skin. Okay. So remember canal cardinal signs, the 4 of them. Okay. Next question. Is there any doubt? Shall we move on to the next question? Okay. A 12-year-old boy, known case of hypothyroidism, presents with pain on his left hip. His weight was found to be 70 kg. He is unable to walk, and on examination, left hip is externally rotated and adducted. What is the most probable diagnosis? Very good, Regan. Parikshit, Arafat, absolutely right. You're all correct. This is the classical presentation of slip capital femoral epiphysis, isn't it? Slip capital femoral epiphysis. For those who don't know, let me explain. This is also a very, very important question. This is from a previous year topic. Okay, very, very important. So I'll first draw a normal femur. In an adult, this is how the femur will look, isn't it? But in a child, remember, there is no femoral neck. Instead of the femoral neck, you have the physis there. What is the physis? This is the growth plate. Okay, growth plate will be there. And the growth plate sometimes becomes very weak due to some reasons. And when the growth plate becomes weak, when the patient walks, the femoral head will slip down like this. Femoral head should be here. It will slip down like this. This is what is called as slip capital femoral epiphysis. We do not know why this happens, but there are very important risk factors. Risk factors. First is age. Age is between 12 to 16 years when puberty happens. That is a risk factors. Then gender. This is more common in males. What else? Obesity and hypothyroidism. Hypothyroidism. These are the 4 important risk factors. And if these things are there, the child can develop a slip capital femoral epiphysis, and the child will come to you unable to walk because of the severe pain, and on examination, the hip will be externally rotated and adducted. You don't have to learn those things, but remember these important points. You can see that the age is between 12 to 16. It is a boy. The child has hypothyroidism, and the child is weighing 70 kg. Can you imagine a 12-year-old child with 70 kg weight? Obviously, the child is very obese. So all these factors put together, it points towards slip capital femoral epiphysis. Okay. This, yes, Vinay, you are correct. There is obesity in this child. That is one of the most important or the most common risk factor for developing slip capital femoral epiphysis. Okay. So this is the typical pattern of question regarding slip capital femoral epiphysis. Please learn this clinical vignette. Okay. Okay. Shall we go to the next question? Again, CTEV, very, very important previous year topic, very often asked for question. What is CTEV? What is CTEV? Abra is asking FMG or NEET. I am focusing on FMG, okay? Not NEET. CTV is congenital talipes equinus varus, also known as clubfoot. Yes, absolutely correct, Vivek. Clubfoot. This is clubfoot. Okay. And now tell me, how do you treat clubfoot? That is a very often asked question in FMG, treatment of clubfoot. How do you treat clubfoot? By putting serial cast, isn't it? Serial cast. And what is that technique called? What is the technique of putting serial cast called? It's called the Ponseti technique. Ponseti technique. Okay. So when a child comes to you with clubfoot, you correct the deformity and put cast, serial cast every week for about 1 or 2 months. And at the end of 2 months, usually the deformity will completely disappear. Okay. But the problem is that even if the deformity completely corrects, till the child is around 5 years of age, there is a high chance of recurrence. There is a high chance of recurrence. Okay, recurrence is a very, very important problem in CTEV. In order to prevent recurrence, we give a certain kind of braces and shoes for the child. One important shoes that we give is CTEV shoes for correcting CTEV. Okay. So what are the features of CTEV shoes? Please listen to me carefully here. Normally, our shoes have a curve on the inner border, isn't it? We look at that curvature to see which shoe goes into the right side and the left side, isn't it? That is how we all do it. So, all normal shoes will have an inner curvature in the inner border. CTV, it will be absolutely straight. Okay, so there will be a straight inner or medial border. Then the sole of the foot will be of uniform height in a normal shoe. But there will be an outer or a lateral raise in the case of a CTV shoe. And normally our shoes have a heel. In a CTV shoe, there won't be any heel. So straight lateral border or a straight medial border. So sorry, lateral shoe raise and absent heel. All these are features of CTV shoes. Medial arch support is not there. Okay, medial arch support is not a part of CTV shoe. Now, can you identify this splint? Again, previous year question. Can you identify this splint? Two shoes connected by a central rod. Again, used in CTV. Very good, very good. Dennis Brown splint, isn't it? Dennis Brown splint. So whenever you learn about Dennis Brown splint, please read about CTV shoes as well, because both of them are very, very important in treating CTV. Okay. Next question, very, very easy question, isn't it? Very often asked, previous year question. 3-year-old child presents with lethargy and bow legs. Her wrist X-ray is shown in the image. What is the diagnosis? Come on, I know all of you know the answer. Come on, type it in. Yeah, very good, very good. All of you are absolutely right. This is rickets. They said that if a child's wrist X-ray is kept for your exam, it is probably rickets. So what are the features here? So remember that whenever there is rickets, the maximum changes will be in the wrist. Okay. That is why we take wrist X-ray. And even in the wrist, the metaphysis will be maximum affected. Metaphysis. So in the bone, this is the metaphyseal region. What are the changes? First thing you see is that there is widening here, isn't it? Almost like a funnel. This is called splaying of metaphysis. Then you can see that there is a depression here. This is called cupping of metaphysis. And finally, you see that there is some hair-like endings here, which is called fraying. So in the metaphysis, you will see splaying, cupping, and fraying. Splaying, cupping, and fraying. 3 classical features of rickets. Okay. Whenever this X-ray is kept, all the classical findings will be usually there. So please learn this X-ray by heart. Very often asked for exams. Very, very important. Okay. All right. Next question. A 25-year-old female presented to the OP with generalized body ache and fatigue. X-ray of her pelvis showed looser zone. What is the treatment? Very good, Vivek. Very good, Mupin Chandra. Absolutely right. What is this looser zone? What is this looser zone? I'll show you an X-ray. Okay. Sometimes certain conditions produce, especially one condition produces severe weakening of the bone, and this will produce small fractures. Can you appreciate a small fracture in the neck of the femur here? There is another small fracture here in the superior pubic ramus, another small crack here. So these small fractures in bone, especially in the pelvis, are called looser zone, and this is seen in one condition, osteomalacia. And what is osteomalacia? It is vitamin D deficiency in an adult. Rickets is vitamin D deficiency in a child. Osteomalacia is vitamin D deficiency in an adult. Okay. So let's look at the options. Do you need radiotherapy for this? No. Denosumab injections? No. Open adduction internal fixation for tiny fractures? No. What is the answer here? This is vitamin D deficiency. You have to treat it by vitamin D supplementation. Very, very simple treatment. Though if you have to answer this question, you need to know where you see looser zone. That is the key. Remember, looser zone is seen in osteomalacia. Osteomalacia. Okay. All right. Yeah, Abhishek is saying milkman lines. Yes, looser zone is also known as milkman lines. Okay, milkman lines. Very good, Abhishek. Looser zone and milkman lines are the same. Pseudo fracture is also correct. Yeah. Pseudo fracture is also correct. Yeah. So three names for the same thing. Looser zone, milkman fractures, and pseudo fractures. So you have told all these things. So tell me, why is it called loser? Who has lost things? Who is losing things here? Why is it called milkman fracture? What did the milkman do to get this fracture? He did not drink his own milk. Is that the reason? Milk gives vitamin D. No, loser is, I think, loser and milkman are both names of the people who described this. Okay, Jeffrey Milkman and I think Gustav Loser. Both of them described this condition. Okay, that is why it is called loser zones and milkman fractures. Nothing to do with milkman adding water to milk and all. Okay, Vinay. Okay, don't get confused. There is nothing to do with being a loser and all. Okay. So these are all names. Okay, next question. A 50-year-old diabetic and alcohol patient presented with flexion deformity of his ring finger. Very easy question, isn't it? Thick cord-like structure palpable in the palmar aspect of ring finger. What is the diagnosis? Diputans contracture. Well done. Very good. Very good. So you look at the picture, you can clearly see this cord, isn't it? There is this cord-like structure which contracts and causes the flexion of the finger. Okay. Now I'll just tell you how this has happened. So what happens is that in our hand, we have the superficial palmar fascia or the superficial palmar aponeurosis. There will be nodular hypertrophy there, nodular hypertrophy. Why this happens, we do not know, but it is usually associated with alcoholism and diabetes mellitus. Okay, usually associated with alcoholism and diabetes mellitus, but these are not the exact causes. Exact causes unknown. So there will be nodules like this that automatically form, and over the period of time, these nodules will connect together to form cords. These cords are contractile. So when these cords contract, what will happen? Our poor ring finger is going to flex like this. Okay. So that is your Dupuytren's contraction. Okay. Next question. A 30-year-old lady, known case of hypothyroidism, presents with pain in the base of the right thumb for last 3 months. On examination, tenderness is there on the radial styloid. Finkelstein test is positive. What is the diagnosis? This is a previous year topic. What is the answer? Yes, again, Arun, Abra, Arafat, Ginny, absolutely correct. The answer is decurvane stenosynovitis. What is decurvane stenosynovitis? The definition was asked as an MCQ earlier, I think 2 or 3 years back in FMGE. It is a inflammation of two tendons, abductor pollicis longus and extensor pollicis brevis. Abductor pollicis longus and extensor pollicis brevis tendon inflammation usually occurs whenever you overuse your thumbs. You are playing what? Games on the mobile for a long time, or you are chatting with your girlfriend on WhatsApp for a long time. All these things can cause your decurvane stenosynovitis. Okay. So generally people confuse between APL EPB and EPL APB. So in order to clear that confusion, remember this picture. Okay. So someone holding an apple. So decurvane stenosynovitis involves the tendons here. So apple is what? APL. Okay. So APL and EPB. So remember APL and EPB are involved and not EPL and APB. Please remember that. Okay. So this question was asked as a MCQ earlier. So this is very, very important topic. Okay. So the two tests for decurvane stenosynovitis are Finkelstein test, where you catch hold of the thumb of the patient and you ulnar deviate like this. This will stretch the tendons and it will cause pain. Second, there is something called Akoff test, where you ask the patient to keep the thumb inside the palm and ulnar deviate the wrist like this. And this will again cause pain here. That is Akoff. You don't have to know the test in detail. Please remember Finkelstein and Akoff tests are tests for recurrent stenosynovitis. Okay. Someone is asking males or females. Females are more commonly affected than males. Okay. And the treatment, you can use a thumb spica splint. Treatment is by putting a thumb spica splint. If that doesn't work, you can give steroid injections. Okay, steroid injections. These are the two commonly used treatment. If that also doesn't work, you can do surgeries, but those are not important. These questions are not going to be asked for you. Remember the tendons involved, the clinical miniate and the test. That's all. Okay, next question, very, very easy question, previous year question. Again, tell me the answer. What is the diagnosis? 25-year-old male presents with weakness of grip as after injury. The test is positive. What test is this? Very good, very good. This is the pen test, isn't it? Pen test. Pen test, where you ask the patient to, you hold a pen over the thumb and ask the patient to abduct the thumb and touch the tip of the pen. This is your pen test, and pen test is used for which nerve? Median nerve. And which muscle are you testing? The muscle tested is? Very good, very good. Abductor pollicis brevis. Abductor pollicis brevis. Very good, guys. So pen test and the test for ulnar nerve, like card test and all, are very often asked for exams. So please remember to learn all those important tests. Okay. So moving on. In which nerve injury is the splint shown in the image used? Can anyone tell me? Again, an easy question, isn't it? Which splint is this? What is the name of the splint? Very good, Atul. This is the Arun, absolutely correct. Subramaniam, correct. This is the knuckle bender splint. The knuckle bender splint. Can see that the knuckles or the metacarpophalangeal joints are kept in flexion, isn't it? The idea of the splint is to keep the metacarpals in flexion. So this is used for which deformity? Claw hand deformity, and claw hand is seen in ulnar nerve injury. In ulnar nerve, you get the claw hand deformity. In order to correct it, you give the knuckle bender splint. All right. Next question. A 35-year-old male presented with neck pain and paresthesias of the right upper limb for 3 months. Test shown in the image is positive. What is the diagnosis? This test and the questions regarding this have been asked very often for the last 2 years in NEET and INECT. So I think this could be asked again in FMG as well. What test is this? Very good, guys. Sajan, absolutely correct. This is the AdSense test. AdSense test, and it is positive in thoracic outlet syndrome. What is this thoracic outlet syndrome? See, there are several structures in the lower part of the neck which form a triangular area, which is called the thoracic outlet. And inside the thoracic outlet, we have the brachial plexus and the subclavian vessels. Okay. So generally, in thoracic outlet syndrome, there will be compression of the brachial plexus. Because of the compression, the patient will get paresthesias of the upper limb. When rarely subclavian vessels can also be compressed. If that happens, you get a positive AdSense test. Okay. What is this positive AdSense test? It is a very simple test. The examiner stands behind the patient and examines the radial pulse. He's actually holding onto the hand and examining for the radial pulse there. And he asks the patient to turn to the same side of the hand. So what happens if there is any thoracic outlet obstruction? what will happen to the radial pulse? Sometimes it will completely disappear, or the pulse volume will reduce dramatically. If both these are there, then the Adson's test is positive. Okay. So always remember Adson's test for thoracic outlet syndrome. Even if you don't remember the test, don't remember the details of thoracic outlet syndrome, doesn't matter. Remember Adson's test is for thoracic outlet syndrome. That much at least you need to remember. Okay. Very, very important point. Okay. Shall we move on to the next question? So Abhishek is asking whether it is similar to Halsted test. Halsted test is reverse Adson test. Okay. Here the examiner is examining the right hand and the patient is turning to the right side. That is your Adson's test. In Halsted test, the examiner will examine the same side and the patient is asked to turn to the opposite side. That is Halsted test. Okay. Halsted test is reverse Adson's test. Okay. So I don't think you have to go into the details of Halsted test and all those. I don't think they are going to ask that. Adson test is important. Okay. Next, a 50-year-old woman on long-term steroids for pemphigus vulgaris presents with pain in the left hip. X-ray shows flattening of femoral head with crescent shape area in the subchondral region. What is the diagnosis? What is the diagnosis? There are two clues here, steroids and hip pain. Steroid plus hip pain means which condition? Steroids, hip pain in a patient with on steroids is what? Yes, very good, very good. Avascular necrosis of femoral head. Avascular necrosis of femoral head. Okay. Again, this is a very, very important concept. Those who did not get it right, please listen to me here. Whenever in the question, there is someone taking steroids and the patient has hip pain, the answer would be avascular necrosis of femoral head. Okay, that is the direction that the examiner is asking you to take. Okay, very, very important. Now, what is this avascular necrosis of femoral head? So I'll very simply explain this to you. So you have the femoral head like this. What happens is that you have the blood supply coming in like this, isn't it? Due to some unknown reasons, which is idiopathic reasons, the blood supply to the femoral head will be completely cut off. What happens because when the blood supply gets cut off? When the blood supply gets cut off, the entire femoral head will become necrotic. It will become necrotic or it will become dead. That is what is called as avascular necrosis, complete death of the femoral head without getting blood supply. Okay. Now, what happens when the bone is dead? The bone becomes very soft. So the femoral head will become very soft and it will completely collapse like this. It will completely collapse like this. And this is what causes the hip pain. This is called your avascular necrosis of femoral head. Okay. So we do not know the exact cause of avascular necrosis of the femoral head, but there are certain risk factors, and the most important risk factors is steroid use. Okay. Steroid use is the most important risk factor. Second risk factor is alcohol use. There are several conditions such as pemphigus vulgaris or nephrotic syndrome. In all those conditions, the patient may have to take steroids for a long time. Okay. And these can cause the avascular necrosis. Sometimes athletes will take steroids for building up their body, isn't it? And for increasing their athletic performance. They can also get avascular necrosis of the femoral head. Okay. So this is the most important risk factor. And when the femoral head collapses, sometimes it appears like this. This is what we call as the crescent sign. Okay, crescent sign. So always remember crescent sign is also seen in association with avascular necrosis of femoral head. That is why they are saying that there is a crescent shaped area in the subchondral region. This is the crescent sign. So I hope you understood. there is loss of blood supply to the femoral head whenever there is increased steroid intake, and this is going to cause collapse of the femoral head and hip pain. This is avascular necrosis of femoral head. So someone is asking, is it seen in pediatrics? Pediatrics also this is seen, but remember that pediatric avascular necrosis of the hip is completely different from adult avascular necrosis of the hip. Both of them are not related to each other at all. That is called Perthes disease. When avascular necrosis of the femoral head occurs in a child, that is a completely different disease. You don't have to worry about that. Okay, this is different. So someone is asking, why is medial circumflex artery which supplies the femoral head gets cut off? I also don't know. Researchers are still going on. Research has been going on for the last 30 years. We have no idea why this happens. Okay, that is why it is called idiopathic. We have no idea. Okay, shall we move on? Next question. Identify the deformity shown in the figure. Very, very easy question, isn't it? What is this? You can see that there are two problems. One, there is a flexion. There is flexion where at the proximal interphalangeal joint, and there is an extension where extension is at the distal interphalangeal joint. And this is what is called as the boutonniere deformity. Boutonniere deformity, okay? So very, very important question. Boutonniere deformity, when there is a flexion at the proximal interphalangeal joint and extension at the distal interphalangeal joint. This is boutonniere deformity. Where do you see boutonniere deformity? Can anyone tell me? It is seen in rheumatoid arthritis. So now can you identify this deformity? This is a previous year question. Can you identify this deformity? Yeah, this is the reverse of boutonniere deformity where you have a extension at the PIP and a flexion at the DIP. This is what is called as the swan neck deformity. Okay. Swan neck again is seen in rheumatoid arthritis. So please do not get confused between swan neck and boutonniere deformity. Learn both these diagrams correctly. Okay. Some of them are asking about mallet finger. In mallet finger, the proximal interphalangeal joint is completely normal. Only there will be flexion of the distal interphalangeal joint. The tip of the finger will be flexed. The proximal interphalangeal joint will be absolutely normal. Okay. So someone is asking difference between flexion and extension. Flexion, you can remember it like this. When you are closing the joint, it is flexion. When you are opening the joint, it is extension. Okay. This is flexion. When the two parts of the body come together, this is flexion. This is extension. So this is applicable everywhere. In the fingers also, this is flexion. This is extension. Okay. So next question. A 30-year-old male presents with back pain for the last 3 years. He has occasional episodes of red eye and reduced chest expansion. His X-ray is given below. What is the diagnosis? Previous year question. What is it? Very, very easy question, isn't it? So this is the classical bamboo spine that you see in your X-ray. Isn't it? You can see that all the vertebrae are fused together to form what we call as the bamboo spine. And all the clinical features, reduced chest expansion, red eye, a 30-year-old male, everything points towards your ankylosing spondylosis. That is the answer. So why does the patient get the red eye? Can anyone tell me why does the patient get a red eye? Very good, Arafat. Absolutely correct. It is because of uveitis. It is because of uveitis. Uveitis is the most common extra-articular manifestation of ankylosing spondylosis. What is extra-articular manifestation? Where there is an affection of your ankylosing spondylosis in an area outside the skeletal system. Most commonly, it occurs in the eye where there will be ankylosing spondylosis. And yes, in more than 90% of the patients, They will have HLA B27 positivity. Okay, HLA B27 positivity. That is also correct. Adul, you are correct. Next question. A 60-year-old lady presented with pain in her right knee for 2 weeks. On examination, there was effusion in the knee. X-ray showed calcification of menisci. Arthrocentesis was done, which showed positively birefringent rhomboid crystals. What is the diagnosis? What is arthrocentesis? Arthrocentesis. People are fighting between gout and pseudo gout. But tell me what arthrocentesis is. Yes, aspiration of joint. Okay. So when you're putting a needle into a joint and aspirating the contents, you call it arthrocentesis. This is nothing but aspiration of joint. Okay. So let me tell you. So in this question, we have seen that there are some crystals inside the joint, isn't it? So this means that this is a crystal arthropathy. Crystal arthropathy. What does that mean? It means that some kind of crystal has deposited inside a joint and it has destroyed the joint. That is your crystal arthropathy. So two types of crystals can get deposited. One is your monosodium urate, or there could be calcium pyrophosphate dihydrate, MSU or CPPD. When MSU is deposited, you call it gout. When CPPD is deposited, you call it pseudo gout. So it is not septic arthritis, not osteoarthritis. It is either gout or pseudo gout. So let's see the differences. So this is a very, very important table. You can learn this table. So gout is seen in middle-aged men, around 50-year-old men. Pseudo gout is seen in elderly females above 60 years. And gout usually affects the smaller joints of the foot, especially the first metatarsophalangeal joint. While pseudo gout affects the larger joint, especially the knee joint. In gout, the pain will be very severe. In pseudo gout, it will be severe, but not as much as gout. The crystal deposited would be MSU in gout, CPPD in pseudo gout. And when you take X-rays in gout, there will be erosions, and in pseudo gout, there will be calcifications. I'll show you. So the best diagnostic method to differentiate between gout and pseudo gout is aspirating the joint and looking at under the microscope. So what do you see? Whenever there is MSU or monosodium urate crystals, it will be negatively birefringent and needle shaped. Okay. So remember it like this. So Na is sodium, isn't it? Na is sodium. So in monosodium urate, Na, you get needle-shaped crystals which are negatively birefringent. All these are N. So needle-shaped, negatively birefringent, Na, sodium urate, monosodium urate is your gout. What about pseudo gout? You get CPPD crystals which are rhomboid shaped and positively birefringent. Okay. So this is how you differentiate using a arthrocentesis. While taking an X-ray, also there is something different. In gout, you get erosions like this, erosions. And this kind of erosion is called Martel's G sign. Martel's G sign. This was asked earlier in NEET exam. So I'm just writing it here. Martel G sign. Martel G sign. In the case of gout, in the case of pseudo gout, there will be calcification. Can you see this whitish deposition in the meniscus? This is your calcification inside the meniscus, which is called chondrocalcinosis. Someone is saying rat bite erosions. Yes, that is also correct. These erosions are sometimes called as rat bitten appearance. Rat bitten appearance. You're also correct. Absolutely correct, Vivek. Absolutely correct. Good. So this is also called as rat bitten appearance or Martel's G sign. Okay. Now shall we go back to the question once again? Now tell me the answer here. This is an elderly female. Knee is involved. X-ray shows calcification and there is positively birefringent and rhomboid crystals. What is this? Pseudo gout, isn't it? Pseudo gout. All features of pseudo gout. Okay. So Ashwin is asking dagger sign. Yes, dagger sign is also seen in Dagger sign is also seen in ankylosing spondylosis, where there is a whitish colored line like this in the center of the spine. Okay, that is your dagger sign. Dagger sign is also seen in ankylosing spondylosis. Ashwin, you are correct. Okay. So shall we move on to the next question? Okay, again, recently asked question, which is not part of the terrible triad of elbow. Is the answer? See, terrible triad of elbow is a very serious injury to the elbow where there are three injuries. First, we have fracture of the radial head, then there is elbow dislocation, and there is fracture of the coronoid. Fracture of the coronoid. Okay. So, elbow dislocation, fracture of the radial head, fracture of the coronoid. There is no fracture of the olecranon. Okay. So that is our answer. Fracture of the olecranon is not part of the terrible triad of the elbow. So there is elbow dislocation, radial head fracture, and coronoid fracture. Okay. So you can remember it like this. Terrible red diesel car. Okay. So terrible is for terrible triad of elbow. Red is for radial head fracture. Diesel is for dislocation of elbow. And car is for fracture of the coronoid. You can use this mnemonic for this if you find it difficult to remember otherwise. Okay. Terrible red diesel car. Terrible triad of elbow. Red is for radial head fracture. Diesel is for dislocation of elbow, and car is for coronoid fracture. Okay. Any doubts? All right. So next question. 35-year-old male sustains injury to his right forearm in RTA. X-ray is given below. What is the treatment? Very, very important. Very, very easy question, I would presume. Previous year question, very often asked. What fracture is this? Yeah. Yes, good. So what do you see here? This is the wrist joint. So which is the wider bone at the wrist? It is the radius, isn't it? Radius. And radius is fractured, isn't it? So radius is fractured at the distal third part. And you can see that the radius and the ulna are completely separated. So there is distal radio-ulnar joint dislocation. Usually radius and ulna will be close together. When it is completely separated, you call it distal radio-ulnar joint dislocation. So a distal third radius fracture with distal radio-ulnar joint dislocation is called what? Yes, very good, Vivek. Absolutely correct. This is the classical Galeazzi fracture. Galeazzi fracture. Okay. Galeazzi fracture is important. Why? Always questions are asked regarding treatment of Galeazzi fracture. Why? Galeazzi fracture is a fracture of necessity. What does that mean? Fracture of necessity means that it is a fracture that can be treated only by surgery. So you cannot put casting or anything. The surgery that we do is plate fixation. Okay. Open reduction and plate fixation. This is one fracture whose treatment you should know by heart. Okay. Other fracture treatment are not usually asked, but Galeazzi fracture, because it is a fracture of necessity, is very, very often asked. So there are a few other comments here. Yes, you are correct. Galeazzi fracture is also called reverse Monteggia or Piedmont fractures. And it's not nightstick fracture. Nightstick fracture is a fracture of the ulna. A fracture of the ulna without any radial head dislocation. That is nightstick fracture. Okay. This is Galeazzi fracture. Galeazzi fracture is a fracture of the radius. Okay. So remember, Galeazzi fracture is a fracture of necessity. It has to be treated by surgery. Surgery we do is open reduction and plate fixation. Understood? Okay. Manish is asking if we have to fix the distal radio-ulnar joint. Sometimes we may have to. Sometimes we may have to. I don't think you have to go into the details. Yes, TFCC may also be injured. I think those are all PG level discussions. I don't think you should waste time in those things. Just make sure that you know how to identify Galeazzi fractures on an X-ray and to be able to write the treatment. That is all. Okay. Again, a previous year question. What is the answer here? What is the cast shown in the image below? Very easy, isn't it? The cast is given in what position? What position is this? As if someone is holding a glass, isn't it? This is the glass holding position. Glass holding position. That is one thing. See here that the thumb is also inside. The thumb is involved in the cast, isn't it? Remember that. Why? Because Colles fracture, thumb is not inside the cast. So some of you are confused between Colles cast. Colles cast, please remember, we are not putting it on the thumb. In scaphoid fracture, we are putting cast on the thumb also. This is your glass holding position. This is used in scaphoid fracture. So this is the scaphoid fracture. Scaphoid cast. This is a previous year question. Very, very important question. Okay. Yeah, most of you are correct. This is correct. This is your scaphoid cast. So there are a few other casts that you need to know. One is your handshake cast. That I think most of you will know. This is for your Colles fracture. Glass holding position is for scaphoid fracture. Cast in James position is for boxer's fracture. What is boxer's fracture? Fracture of the boxer's fracture. Yeah, fifth metacarpal neck fracture is boxer's fracture. Then you have cylinder cast, which is useful for patella fracture. This is your cylinder cast. And patellar tendon bearing cast, which is a previous year question, isn't it? They had given this picture for identification. Patellar tendon bearing cast. Please remember that patellar tendon bearing cast is for tibia fractures and not for patella fractures. Okay. Patellar tendon bearing cast is a below knee cast, which also covers the patellar tendon. That is your patellar tendon bearing cast used for tibia fractures, not patella fractures. Okay. Will you remember this? Not patella fractures. Okay. Very, very important. Next. A 6-year-old child sustained supracondylar fracture of the humerus and was treated using a slab. After a few hours, the child developed severe pain in the forearm, which was not relieved by analgesics. On examination, pain was there on passively extending the fingers, but radial and ulnar pulses are present. What is the diagnosis? Yes, very good, very good. I think most of you have got this correct, isn't it? Again, this is a previous year topic, very important topic. Yeah, this is your compartment syndrome. Abra, you are absolutely correct. Jenny, Pratikshit, Karthikeyan, all of you are absolutely correct. This is compartment syndrome. What is compartment syndrome? See, compartment syndrome is a condition where because of an injury, there is an increase in pressure within a muscular compartment. And because of that, there will be necrosis of muscles and soft tissues. And this will cause gangrene of the limb. This is a very, very dangerous complication of fractures. Can you tell me which is the most common fracture causing compartment syndrome? Most common fracture causing compartment syndrome is actually supracondylar fracture of humerus. This is the most common cause of compartment syndrome. Now tell me which is the most common symptom. The most common symptom is pain not relieved by analgesics. This is the most common symptom. And which is the most important diagnostic sign? It is pain on passively stretching the fingers. This is the most important sign of compartment syndrome. All the important things regarding compartment syndrome are in the question itself. The most important cause is supracondylar fracture. The patient has pain not relieved by analgesics. The patient also has pain on passively stretching the fingers. But here, radial and ulnar pulses are present. Is that a problem in diagnosing compartment syndrome? Is that a problem? No, it is not a problem. Please remember that pulse can be present in compartment syndrome. Okay. Absence of pulse is not a criterion for ruling out compartment syndrome. Please remember that. Okay. If the pulse is already gone, then the limb is already dead. Now there is no point in diagnosing the condition. Okay. So remember, absence of pulse is not a criteria ruling out compartment syndrome. Okay, please remember that. So if you look at the clinical features of compartment syndrome, there are 6 P's: pain, pallor, pulselessness, paresthesia, and pain on passive stretch. Please remember, pain on passive stretch is the most important clinical sign. All the others are late signs. They are all late signs and therefore not useful for diagnosing anything. Okay. Pain on passive stretch is what we use. Now, if you want to confirm the diagnosis, you can measure the intracompartmental pressure. What is the level at which you diagnose compartment syndrome? A level of above dash millimeters of mercury is compartment syndrome. What is the answer? Very good, Ginny. Absolutely correct, Ishwar. It is 30. Compartment pressure more than 30 is diagnostic of compartment syndrome. And the surgery that we do is for correcting compartment syndrome is fasciotomy, where we open up all the compartments to relieve the compartment pressure. Okay. Compartment syndrome is a very important topic. Different questions can be asked from the same area. All right. Okay. Next question. Blount's disease presents with which deformity? I think this was a little bit difficult question for you, isn't it? Maybe. No, I guess. I think many of you have got this correct. Good, guys. Absolutely well done. So, Blount's disease presents with genu varum. Okay. What is Blount's disease? It is a condition seen in children where there is an abnormal development of the proximal tibia. So, you have the femur like this, you have the tibia like this. Sometimes what happens is that due to some unknown reason, again, this is an idiopathic condition where there is abnormal development of the proximal part of the tibia and the tibia will be like this. So, when the child walks, the tibia will go like this, resulting in which deformity? Genu varum. So this is the deformity that you see. That will be severe genu varum. Okay. So please remember, in Blount's disease, there will be severe genu varum. And when the child walks, there will be an abnormal gait. Can anyone tell me what is the abnormal gait called? What is the name of that abnormal gait? It is called Siffert cat's sign. Siffert cat's sign. Okay. So remember just 2 points in Blount's disease. It causes genu varum in children. It causes Siffert cat's gait. Okay. That is all that you have to learn in Blount's disease. Okay. Genu varum and valgum, I am coming to it. Okay. There are a few slides where I teach you that. So please wait for it. Okay. It is coming. Next question. Identify the angle shown in the image. Very easy question, isn't it? Can see that the spine, this is a picture of the spine and the spine is bent like this. What do you call the lateral bending of the spine? What do you call this? What do you call the lateral bending of spine? Scoliosis, correct. This is scoliosis, correct, scoliosis. And how do you measure scoliosis? Which angle? There is only one angle that you will have to learn in spine. That is your Cobb's angle. Cobb's angle. Cobb's angle is used to measure scoliosis. Okay. You don't have to worry about how you measure and all. It's absolutely not required. Just remember, Cobb's angle is for measuring scoliosis. It is an angle in the spine. Okay. Schober test. Again, we are coming to it. Okay. Next question. Which test is used for school screening of scoliosis? Can anyone tell me the answer? Or how do you diagnose scoliosis? Which is the test for scoliosis? Simple question. Very good. Many of you have got this correct. Absolutely correct. This is the Adams forward bending test. Again, a very important question. What is the Adams forward bending test? It is a very simple test. Sometimes a child with scoliosis, it may be difficult for us to diagnose it by looking at the child straight ahead. So what we do is that we ask the person to turn to the opposite side. You stand on the back. Then you ask the patient to bend forward. If there is no scoliosis, the spine will be absolutely straight. But if there is scoliosis, you will be able to clearly see the S-shaped curve like this. And you'll also be able to notice a bump here, which is called the rib hump. Rib hump. Rib hump will become evident when the child or the patient bends forward. Okay. So this is your Adams forward bending test for identifying scoliosis. Now the same test is used for school screening program. See, in Western countries, there is a higher incidence of scoliosis. So what they do is that all children between 12 to 16 years of age, they will check for scoliosis using the Adams forward bending test. So they ask the children to bend forward and they use something called as a scoliometer. Scoliometer. They use the scoliometer to measure this angle. If there is a hump like this, and if this angle is more than 7 degrees, the child is sent to a spine surgeon. Okay, that is all. So if otherwise, if the child is normal, then nothing is required. If they are suspecting something, then they send the child to a spine surgeon. So remember, there is school screening of scoliosis in Western countries, and the test they use is again what we all routinely use for scoliosis, Adams forward bending test. Okay. Shall we go to the next question? What is spina ventosa? Must be something related to spine, isn't it? The very often asked question because it sounds like something to do with spine, but it actually does not have anything to do with spine. It is actually TB of fingers. Spina ventosa is another name for TB dactylitis. What is dactyl? Dactyl means fingers, isn't it? Polydactyly and all. So dactyl is fingers. When there is infection, TB infection of the fingers, you call it spina ventosa. It has nothing to do with spine. So remember this, okay? Spina ventosa, TB of the fingers. So this you can see there is a lytic lesion there. That is the classical spina ventosa. There are 4 important named TB infections that are often asked in exams. Okay. One is port spine. You all know what port spine is, isn't it? It is TB spine. That is easy. Spina ventosa, we discussed. It is TB dactylitis, infection of the fingers. Then you have something called caries sicca, which is tuberculosis of the shoulder. And this is the dry type tuberculosis of the shoulder, which means that there is not much of pus. There will be pain and stiffness of the shoulder, but there won't be much pus. That is your dry type TB shoulder, which is called caries sicca. And finally, there is called something called as Ponson's disease, where there is reactive polyarthritis, which is seen in tuberculosis. That is all you have to learn. Reactive polyarthritis. Okay. So please remember these 4 MCQs. You never know which one is going to be asked. Port spine, spina ventosa, caries sicca, and Ponson's disease. All these are associated with TB, even though they do not sound like something related to TB. Okay. So please remember this. Okay. Shall we move on to the next question? Which is not part of the triple deformity. You want to go to the last slide? Don't worry, I am going to give you the PDF. Don't worry at all. I'll give you the annotated PDF. Don't worry. Okay, everything will be given to you. It is not a part of triple deformity of knee. Where do you see triple deformity of knee? Can anyone tell me? Very good, very good. It is seen in TB of knee. And whenever there is tuberculosis of the knee, and if you are not treating it properly, the knee will become something like this. And there will be 3 changes. I will show you. Normally, your tibia should be somewhere here. That is the normal position of the tibia. There will be a posterior subluxation of the tibia. That is one thing. Secondly, the entire tibia will be externally rotated. And third, there will be a flexion deformity of the knee. So 3 things which we usually remember using the mnemonic PERF. PERF. PERF, P is for posterior subluxation, ER for external rotation, and F for flexion of the knee. Three important deformities. Remember, there is no genu varum. There is no genu varum. Posterior subluxation, external rotation of tibia, and flexion of the knee. So there is no genu varum. That is the answer here. Okay. Next question, very, very easy question, but previous year question, so important. A 13-year-old boy presented with a swelling in the right thigh. His X-ray is given below. What is the diagnosis? Very easy, isn't it? I think all of you have got this correct, isn't it? If you have any doubts in this question, you must ask me because it is very simple and it has been asked multiple times previously. You can see that in the metaphyse of the distal femur, there is a lesion with a pedicle and a swelling like this, isn't it? This is a classical description of osteochondroma. Osteochondroma. You can see that it is from the distal metaphyse of the femur and there is a pedicle and a swelling and the tumor always grows away from the joint. So there will be a tumor which will be growing away from the joint. Okay. So osteosarcoma, everything is coming. Don't worry. Okay. All the options, we have questions coming up. So we'll be discussing about all those things later. Okay. Sairam. We'll be discussing about those later. Okay. So this is the classical osteochondroma. Okay. So you can easily make a diagnosis of osteochondroma using an X-ray. But there are a few other important MCQs that are often asked around osteochondroma, which you need to know. So first is, can you tell me which is the most common cause of pain in osteochondroma? Why could there be pain in osteochondroma? The most common cause is bursitis. Most common cause is bursitis. Okay. Yes, very good, Karthikeyan, because there could be an inflammation of a bursa around the growing osteochondroma. That is the most common cause. Which is the most dangerous cause of pain in osteochondroma? Most dangerous cause of pain is malignant change. Malignant change. Okay. Another question very often asked is, what kind of malignancy does osteochondroma produce? Can anyone tell me? Is it osteosarcoma or chondrosarcoma? Abra is saying chondrosarcoma. Is that correct? Yes, very good. This is chondrosarcoma. Okay, chondrosarcoma. Please do not think that osteochondroma give rise to osteosarcoma. No. What occurs is chondrosarcoma. Why? Because all osteochondromas have a cartilage cap. This is your cartilage cap. And it is the cartilage cap that becomes the malignancy. So cartilage cap is what turned malignant. So you get a chondrosarcoma, which arises from the cartilage. Okay. Now, again, a very important question, very often asked is, how do you assess whether osteochondroma has become malignant or not? For that, what you do is that you measure the thickness of the cartilage here, cartilage cap. You can use an ultrasound scan to measure the cartilage thickness. If it is more than 2 centimeters, then it means that there is a high chance of malignancy. So remember, most common cause of pain is bursitis. Most important causes malignant change. Malignancy that arises is chondrosarcoma. And the most important finding in a malignant change is cartilage cap more than 2 centimeters. Yeah, persistent growth, heavy calcification, all these are there. But most important finding that you have to look for while assessing whether there is a malignant changes to measure the thickness of the cartilage cap. If it is more than 2 centimeters, then you have to suspect malignant change. Others can be there, but they are not definitive indicators for malignant change. Okay. Next question. A 45-year-old female presents with paresthesias of her right hand and fingers for the last 3 months. On examination, Fallon's test is positive. What is the most probable diagnosis? Where do you get Fallon's test positivity? This is the classical presentation of your carpal tunnel syndrome, isn't it? What is carpal tunnel syndrome? It is a condition where there is compression of which nerve? Very good, Mupin. It is median nerve. There is compression of the median nerve in the carpal tunnel. And in the carpal tunnel, there would be a very tough and thick flexor retinaculum. flexor retinaculum, which would compress the median nerve and cause all these symptoms. There are a few important tests that you need to learn here. One is obviously your Phalen's test, where you ask the patient to hold the hand like this in forced palmar flexion for a period of 60 seconds. If the patient gets symptoms, then you can say that it is positive. Then you have reverse Phalen's test, where you ask the patient to do a namaste like this and hold the position for 60 seconds. Again, you see if there is any reproduction of symptoms. If that is there, you can make a diagnosis of carpal tunnel syndrome. But if you are asked which is the most important or the best clinical test for carpal tunnel syndrome, what is the answer? Again, a very important MCQ. Which is the best clinical test for carpal tunnel syndrome? Nothing else. It is your Durkan's test. Okay, Durkan's test. So please remember, it is the Durkan's test which is the best clinical test for carpal tunnel syndrome. Here, the examiner uses his thumbs to press on the carpal tunnel of the patient. He does that for a period of 30 seconds. And if the patient has severe paresthesias, then Durkan test is positive. Okay. So please remember, the best clinical test for carpal tunnel syndrome is Durkan's test. Most famous is obviously Phalen's test, but they can ask either Phalen or Durkan in a clinical vignette. Okay. So please remember both Phalen and Durkan test for your exam. All right. Next question. This is a very easy previous year question, isn't it? A 35-year-old male underwent a tumor surgery in the neck, following which he complains of prominence of his scapula while pushing against a wall. Clinical image is given. What is the nerve that is injured? What condition is this? Can see that the medial border of the scapula is very prominent. This is the classical. Yes, very good, Arun. This is the winging of scapula. And this occurs because of paralysis of which muscle? Paralysis of which muscle? Because of paralysis of serratus anterior muscle, and serratus anterior muscle is supplied by the long thoracic nerve, which is also called as which nerve? Long thoracic nerve is also called as the nerve of so also called as the nerve of Bell. Okay, long thoracic. Very good, Safa. Absolutely correct. Absolutely correct, Safa. Kajal, you're all correct. It's also called as the nerve of Bell, long thoracic nerve or nerve of Bell. Shrugging of shoulder is by the trapezius, spinal accessory. Okay, and not the not your long serratus anterior. Okay. Next question again. Previous year question, very easy. All previous year questions you must be thorough with. Okay. What brace is this? Very good. This is the Pavlik harness. You can see that there are certain. What is a harness? Harness means a swing or strings which are used to hold on to something, isn't it? So, like those harnesses, you can see that there are strings or these cloth pieces which are holding on to the foot of the child. The idea is to keep both hips in abduction. Of hip, where the hip is kind of dislocated. Okay. So in those conditions, we will use. Okay. For those conditions, we use Pavlik harness. Pavlik harness is a very important spotter for your exam. Can you tell me this answer? Again, previous year question recently asked. Can see here that two toes are completely stuck to each other, isn't it? What is this? This is syndactyly. Very good. Syndactyly. Syndactyly. There are few other finger abnormalities that you need to know. These are all very easy. You can just tell me the diagnosis. What is the diagnosis here? You can see that the child has one extra finger. What do you call this? Polydactyly. Correct. This is polydactyly. And what do you call this? There is a very large finger there. Very good. That is your macrodactyly. Macrodactyly. And what about this small fingers? Small fingers would be microdactyly. That is all. Microdactyly. Okay. So you can have syndactyly, polydactyly, macrodactyly, microdactyly. So any of these pictures can be asked for your exam. Okay. Next previous year question. Identify the fracture or injury shown in the picture. What is this? Very good, guys. Very good. Very good. Very good. I think most of you are thorough with at least the previous year questions. That is wonderful. Very good. Okay. So this is the classical open book fracture. What do you see here? You see, can see what structure is marked here. This is an X-ray of the pelvis. The structure marked there is the pubic symphysis, isn't it? This is the pubic symphysis. Normally, the pubic symphysis is close together like this. Here, because of an injury, the pubic symphysis has separated out. It has separated out. Sorry. And the both hemipelvises, the right and left hemipelvises has opened up like this, or it has opened up like a book. The hemipelvises are moving laterally like this because the anterior connection is gone. So it will move away like this, like a book. That is why it is called the open book fracture. Very, very important. There are few important named fractures in pelvis. That is also very important for your exam. First, can you identify this fracture, the name of this fracture? An isolated fracture of the iliac wing. Do you know what is this is called? This is called as the Duvernay's fracture. Duvernay's fracture. Okay, an isolated fracture of the iliac crest. What about this? Sorry. There is a transverse fracture of the sacrum. This is usually seen in people who jump from top of buildings for suicide attempts. So do you know what this is called? Yeah. Arafat is coming in with some dark humor. Arafat, don't scare me, man. Okay, this is your jumper's fracture. Okay, this is your jumper's fracture. So when someone jumps like that, there could be an impact on the sacrum, and this can cause a transverse fracture like this in the sacrum. This is your jumper's fracture. Now we have another previous year question. Can you tell me there is fractures of both superior and inferior pubic rami bilaterally? What do you call this fracture? Very good, Ishwar. Absolutely correct. Parikshit, this is absolutely correct. This is straddle fracture. Okay, straddle fracture. Straddle fracture. Okay. So you have the open book fracture, Duvernay's fracture, jumper's fracture, and straddle fractures. So four important fractures that you need to know in pelvis. So next question. Very easy, isn't it? Again, a previous year question. A 35-year-old female complains of pain and swelling in her right wrist for 3 months. X-ray is shown here. What could be the diagnosis? Very good. This is the classical giant cell tumor, isn't it? Don't worry. If you don't know till now, I'll explain. Okay. So remember that giant cell tumor is one of the most commonly asked questions for your exam. And the age is between 20 to 40 years. And it is usually seen in females. Most other tumors are seen in males. Okay. So you can see this is a 35-year-old female. That itself should make you suspect probably this is a GCT. Then in the distal radius, usually tumors are very rare. The most common tumor that can arise from the distal radius is your GCT again. Okay. So remember, distal radius tumors are very rare. If tumors occur, it is probably a GCT. So in a child, if you get an X-ray of the wrist, it is probably rickets. In an adult, if you get a X-ray of the wrist and it is a tumor, then it is obviously a GCT. Okay, you can just remember it that way. Don't write tumors for fractures and all. Right? We are not talking about fractures. Okay, there are no fractures. For a distal radius in a child, it is probably rickets, and distal radius in an adult X-ray would be that of a GCT. Okay. So if you look at the other features, you will see that the tumor is primarily arising from the epiphysis, isn't it? It is arising from the epiphysis and spreading into the diaphysis. So the thing is that you may be confused. Is this an epiphyseal tumor or a metaphyseal tumor? Remember that a metaphyseal tumor will never go to the epiphysis, but the epiphyseal tumor can go anywhere. Okay. So if the epiphysis is involved, this is an epiphyseal tumor. Okay. If the epiphysis is involved, this is an epiphyseal tumor. Epiphyseal tumor, which is eccentric. You can see that it is towards one side. So it is eccentric. So an epiphyseal tumor, which is eccentric and it is expansive. This is the classical definition of a giant cell tumor, which is also called osteoclastoma. Another interesting thing is that there are only two epiphyseal tumors that you need to know. One epiphyseal tumor occurs in a child, other in an adult. The epiphyseal tumor in the child is chondroblastoma. Chondroblastoma, and the epiphyseal tumor in an adult is GCT. So if you see that we are talking about an adult and the tumor is epiphyseal, then the diagnosis is your GCT. So yes, soap bubble appearance is there, but in this X-ray, there is no clear-cut soap bubble appearance. That is why we are not talking about soap bubble appearance in this particular question. Okay. Otherwise, you can get X-rays with soap bubble appearance as well. So please remember that if the tumor is in the epiphysis and if it is an adult, then it is GCT. Okay. If it is in the wrist, any tumor probably for your exam would be a GCT. Okay. Shall we go to the next question? Again, previous year question, painful arc syndrome. Which of the conditions can produce painful arc syndrome? Can you tell me the answer? It's a previous year question. Very important. So I'll tell you what painful arc syndrome is. It is a very, very interesting condition where when you abduct the shoulder like this, there is no pain till the first 60 degrees of abduction. Between 60 to 120 degree, it will be painful. Above 60 degree, above 120 degree, there is no pain. So there is pain only between 60 and 120 degrees. That is called your painful arc syndrome. Painful arc syndrome. The question is, why do you get painful arc syndrome? So if you see, you have the humerus here. This is the humerus. This is the greater tuberosity of the humerus. You have the acromion here. And under the acromion, you have two structures. You have the supraspinatus tendon. Supraspinatus tendon. This is the supraspinatus tendon. And the subacromial bursa. This is the subacromial bursa. Okay. So two things. This is the greater tuberosity. This is the humerus. This is the acromion. And under the acromion, between the humerus and the acromion, you have the subacromial bursa and the supraspinatus tendon. So when you abduct the shoulder, what happens is that when you abduct the shoulder like this, the greater tuberosity will press against the supraspinatus tendon and the subacromial bursa like this. Thus, the greater tuberosity will press. This will happen in all of us. Okay, when you abduct the shoulder between 60 and 120 degree, the greater tuberosity will be pressing on the subacromial bursa and the supraspinatus tendon. But none of us will have pain because we don't have any disease of the shoulder. But if there is any problem with the subacromial bursa, or if there is any problem with the supraspinatus tendon, when this pressure occurs, the patient is going to get pain, isn't it? So what could be the causes? if there is any subacromial bursitis, that is inflammation of the subacromial bursa, or if there is any problem in the supraspinatus tendon, such as inflammation, supraspinatus tendinitis, or a supraspinatus tear, or calcific tendinitis, where there is a deposition of calcium in the supraspinatus tendon. If any of these things are there, when you abduct the shoulder beyond 60 to between 60 to 120 degrees, the greater tuberosity is going to press against this inflamed tissue and it is going to cause pain. So here, what is the diagnosis? It is the supraspinatus tendinitis. Supraspinatus tendinitis is what causes painful arc syndrome. Okay. Shall we move on to the next question? A 24-year-old male presents with knee pain and difficulty in walking after injuring himself while playing football. On examination, Lachman test is positive. What structure is injured? Straightforward question, isn't it? This is anterior cruciate ligament. Yes, that is the answer. So there are a few important tests that you need to know. Sorry. In Lachman test, what you do is that the patient is lying on top of a cot and the knee is flexed to around 20 to 30 degrees, and the examiner will exert a pressure on the tibia anterior to see if the tibia is subluxating. If the ACL is intact, there won't be any subluxation of the tibia anteriorly. But if it is broken, then the tibia will subluxate anteriorly. The examiner would be able to feel it. That is your Lachman test. Even if you don't learn all the nitty-gritties of a test, this table you must learn. The important tests for various ligaments and meniscus injuries. Okay, in the knee. ACL, the tests that you can do to identify an injury are your anterior drawer test, Lachman test, bounce home test, and pivot shift test. PCL injury tests are posterior drawer test, Godfrey sac sign, and quadriceps active test. MCL injury, you can test it by a valgus stress test, LCL by varus stress test, and meniscus injury by McMurray test, or Apley's grinding or Apley's distraction test. Even if you don't learn the nitty-gritties of each of these tests, it is fine. At least you must know the names, so that if they say there is a knee injury and quadriceps active test is positive, then you know that it is PCL injury. Or if they say that the McMurray test is positive, then you know that it is a meniscus injury. Understood? So this table you must learn by heart. Okay. Again, a previous year question for you. A 45-year-old lady complains of back pain radiating to her buttock for the last 1 year. On examination, there is a palpable test in the step in the lower lumbar spine. CT image is given. What is the diagnosis? This is a previous year question, isn't it? Yes, very good, very good. This is classical spondylolisthesis. What is spondylolisthesis? It is subluxation of one vertebra over the other. It is called as spondylolisthesis. Okay, so let's look at the CT image. What do you see here? You can see that this part, this vertebra has subluxed over the underlying vertebra, isn't it? Anteriorly, it has subluxed. And this is the classical finding you see in spondylolisthesis. Is there any other sign that you can get in an oblique view? Very good, Mupin. Absolutely correct. There is something called as the beheaded Scotty dog sign. Not very important, because Mupin had said this. I am writing it. So beheaded Scotty dog sign is another sign, X-ray finding, that you can see in the oblique view of an X-ray in spondylolisthesis. But just remember that spondylolisthesis is the subluxation of one vertebra over the other. And the classical finding is the subluxation that you see on the X-ray like this. Okay. Yeah, Abhishek is saying that inverted Napoleon hat sign is also seen. Yeah, you are also correct. Inverted Napoleon hat sign. That is seen on an anteroposterior view of the X-ray. That is also seen in spondylolisthesis. You are correct. How to treat it? Vinay is asking. Usually, this is a chronic disorder, and you can give physiotherapy, advise them rest, activity modification. You can give lumbosacral corsets for support. That is all that is required. Sometimes there will be a severe listhesis, and there will be involvement of the cauda equina nerve roots. In those conditions, we'll have to do surgery, reduce the slip, and you have to fix it back. So that is your general way of treatment. Usually, it is conservative. So spondylolysis. So someone is asking about spondylolysis. So I'll just tell you briefly. So this is a lateral view of the vertebra. Okay, a simple lateral view of the vertebra. So let's say that this is lumbar 1, L1, L2, and L3 vertebra. Okay. So this is your superior articulating process. This is the inferior articulating process. This is again superior, inferior articulating processes. Okay. So these two areas will come together to form a joint like this. This joint is what we call as the facet joint. Okay, facet joint. Please listen carefully. So this is another facet joint. There are facet joint throughout our vertebral column. Now, the part between the facet joints, the part between the facet joints here, you can see, this is what is called as the pars interarticularis. Interarticularis. Pars interarticularis means part between the articulations or part between the facet joints. So pars interarticularis is very important because it acts as a link between the adjacent vertebrae. L1 and L2 are connected by pars interarticularis and the facet joint. L2 and L3 again is connected using the pars interarticularis and the facet joints. Facet joint injuries are rare, but sometimes what happens is that there could be a defect in the pars interarticularis like this. And a defect in pars interarticularis is called spondylolysis. Spondylolysis. Understood? A defect in pars interarticularis is called spondylolysis. Okay. Now, because of spondylolysis, the connection between two vertebrae are lost. So what will happen? In due course, this vertebra will slip in front of the or above the below vertebra like this. Understood? So this is what is called as spondylolisthesis. Spondylolisthesis. Okay. So you have spondylolysis, which is a break in pars interarticularis. Because of spondylolysis, there is an instability in the spine and one vertebra slips on top of the other. That is called spondylolisthesis. Okay. So I don't think you have to go into the details like this. Just remember the X-ray findings, that is all. When one vertebra slips on top of the other, it is spondylolisthesis. All right. I hope this is clear. Okay. So next previous year question. What is the answer here? Very, very simple question, isn't it? What do you see here? You can see this is an X-ray of the knee. This is the femur. This is the tibia. And you can see that there is a fracture of the patella. How do you treat fractures of the patella? Yes, very good. Tension band bearing. Tension band bearing. There are lots of methods of fixation such as intramedullary nailing, screw fixation, plate fixation. But tension band bearing is interesting because it is a very interesting kind of fixation method. And it is useful in two important conditions. One is patella fracture and other is, can anyone tell me? Used in patella fracture and any other fracture? Olecranon fracture. Olecranon fracture. Olecranon fracture. These are the two fractures where we routinely use. Very good, Garima. Absolutely correct. Well done. Olecranon fractures and patella fractures, we routinely use tension band bearing for fixation. Next question. A 7-year-old child presents with multiple fractures of upper and lower limbs. In examination, there is blue sclera, abnormal teeth, and abnormal teeth. What is the diagnosis? Again, this is a previous year topic question. Previous year topic question. Very good. I think most of you know the answer, no? This is the classical osteogenesis imperfecta. Why? Because there are multiple fractures. Then there is blue sclera and abnormal teeth. All these are classically seen in osteogenesis imperfecta. What is osteogenesis imperfecta? It is a congenital condition characterized by a genetic defect. Can anyone tell me the genetic defect here? In genetic defect in osteogenesis imperfecta? Very good. Collagen type 1. Call 1A gene is abnormal. Okay. So type 1 collagen is either deficient or abnormal. Type 1 collagen is deficient or abnormal. So the bones are very weak. Very weak bones means what? Even the trivial trauma, even if the mother tries to hug the child, there could be fractures. That is the feature of osteogenesis imperfecta. Okay, there will be multiple fractures, but remember that all these fractures will unite properly. There will be multiple fractures, but all these fractures will unite in an abnormal position, causing multiple malunions and deformities. And in the eye, there will be blue sclera, and the teeth development will not be normal, again because of type 1 collagen deficiency, resulting in something called as something called as dentigenous imperfecta. Yeah, it is also called brittle bone disease. Absolutely correct. Vivek is seeing that there is sensory neural hearing loss. That is also absolutely correct. Okay. So it is a very, very difficult condition to treat. We have very little to offer for osteogenesis imperfecta. Even when, have you seen a child with osteogenesis imperfecta being brought to the hospital? Even for showing a small fever of the child has to be brought in an ambulance. A big setup has to be made. The child is actually covered by 5-6 pillows all around so that there are no fractures that occur again. Even if the ambulance fall inside a gutter, there would be that jolt is enough to produce fractures. So that is the heartbreaking situation of children with osteogenesis imperfecta. Okay. So remember the clinical vignette. Next question. 16-year-old child. Vinay is asking what can we offer to improve collagen? We have nothing to offer. We have no treatment for osteogenesis imperfecta. We give them a bisphosphonate to reduce the incidence of fractures, but there is no way to treat. Okay. 16-year-old male patients with chronic osteomyelitis of humerus, X-ray is shown below. What is the diagnosis? Very, very important topic. In chronic osteomyelitis, this structure is what is most commonly asked. What is it? So we can see that this is an X-ray of which bone? X-ray of humerus. And you can see that there is a large lytic area in the metaphysis. It is, the question itself says that it is chronic osteomyelitis, so it is infection. And inside this, you can see that there is a piece of bone, isn't it? There is a piece of bone which is whiter than the surrounding bone. Okay. What is this? A piece of bone which is whiter than the surrounding bone is always dead. So this is a dead piece of bone, and dead piece of bone in osteomyelitis is called sequestrum. Okay. The answer here is sequestrum. Very, very important. So remember these definitions. Very often, few of these things are asked in exams. Sequestrum is a piece of dead bone inside an abscess cavity which harbors bacteria. Involucrum is the new bone that is formed around the sequestrum and the abscess. Cloaca, remember, is an opening in the involucrum through which pus and debris come out. And sinus is an opening in the skin through which pus comes out. So if you look at this clinical picture, what is the structure, the piece that is lying inside the cavity? What is this? What is this? This is your sequestrum, correct. This is your sequestrum. What about all these white new bone that is formed around the sequestrum? What is this? This is your involucrum. This is your involucrum. What about this large opening that is seen here? In the involucrum, there is a large opening through which pus is coming out. That is your cloaca. So usually there is confusion between cloaca and sinus for the students. Remember that sinus is an opening in the skin. S for sinus, S for skin. Okay, cloaca is opening in the involucrum. Sinus is the opening in the skin. Do not get confused between the two. Okay, sequestrum is dead bone. Involucrum is new bone. Cloaca is opening in the involucrum for pus to come out. And sinus is the opening in the skin for pus to come out. These four things you will have to learn for your exam. Very, very important. So these are the X-ray findings. You can see that this is the abscess cavity, and this white thing that you see inside the abscess is what, which is whiter than the surrounding, is your sequestrum. That is your sequestrum. And what do you call this opening here through which pus comes out? Yeah, that is the cloaca, correct. That is the cloaca. What about this thickening in the bone, the new bone that is formed? What do you call that? That is your involucrum. Okay. So these four things you have to know the definition, and you have to identify these things on an X-ray as well. Okay. Shall we move on to the next question? No, X-ray, on an X-ray, only cloaca will be seen. Sinus won't be seen on an X-ray. Okay, sinus is in the skin. Okay. Cloaca will be seen on an X-ray. Sinus cannot be seen on an X-ray. It will be seen outside on the skin. Okay. So next question. A 12-year-old child presents with a swelling in the right thigh. The swelling is painful and rapidly increasing in size. The X-ray is given below. What is the diagnosis? Garima, osteoblastoma. Osteoblastoma occurs in the spine. Okay. So for your level, osteoblastoma is not required at all. You don't have to study about osteoblastoma at all. You can forget about it. Okay. For none of your questions, osteoblastoma will be an answer. That is kept for an option. That is all. The other three can come as a answer in your question. So let's look at one of the options one by one. Can it be osteoclastoma, which is giant cell tumor? Can it be? Just look at the age. What is the age of osteoclastoma or a giant cell tumor? 20 to 40 years. What is the age of the child? 12 years. Can it be osteoclastoma? No, it cannot be osteoclastoma. Okay. So it cannot be osteoblastoma also, because osteoblastoma occurs in the spine and not anywhere else. So we have two options, osteosarcoma and Ewing sarcoma. Okay. Which is the most common tumor in the first decade of life? Before 10 years of age, which is the most common malignancy? Before 10 years of age, the most common malignant bone tumor is Ewing sarcoma. After 10 years, which is the most common malignancy? It is osteosarcoma. So just look at the age of the child. That itself will give you a clue that it is probably osteosarcoma. Okay. Then next, let's look at the other options. There is a painful swelling which is increasing rapidly in size. And look at the X-ray. So you can see that there is a swelling here, isn't it? Swelling here. Which part is it affecting? Is it the epiphysis, metaphysis, or diaphysis? You can see this is the epiphysis, this is the metaphysis, and this is the diaphysis. Okay. So so people are asking how to differentiate osteosarcoma and Ewing sarcoma. Don't worry, I'm giving you the differences. One, Ewing sarcoma usually before 10 years, osteosarcoma after 10 years. Next, what do you see? The tumor is arising from the metaphysis. Which tumor arises from the diaphysis? Ewing's. Ewing's arises from the diaphysis, and which arises from the metaphysis? Osteosarcoma. Understood? So again, we are going towards osteosarcoma. But there is a clinching evidence here that this is definitely osteosarcoma. That is why this X-ray has been kept. Okay? There is a clinging evidence for osteosarcoma here. Can you tell me? What is this triangular area seen here? Both sides. Triangular area of newborn formation seen in tumors. Yes, this is Codman's triangle. Codman's triangle is classically seen where? In osteosarcoma. Okay. So this is osteosarcoma. First, age 10, between 10 to 20 years, it is most probably osteosarcoma. Second, osteosarcoma is arising from the metaphysis. Ewing sarcoma will arise from the diaphysis. The periosteal reaction. Codman's triangle is classically seen in osteosarcoma. Ewing sarcoma, we see something else. What kind of periosteal reaction? We can see onion peel periosteal reaction. Very good. Onion peel periosteal reaction. Osteosarcoma can also produce other things like sunburst appearance and all. For this question, we have Codman's triangle, which is classical of osteosarcoma. Just looking at the X-ray, if you notice the Codman's triangle, you don't have to worry about anything else. You can write osteosarcoma. So that is our answer. Okay. The answer is osteosarcoma. Next question, previous year question, recently asked. Gokul is asking sundry appearance. Sundry appearance again osteosarcoma. 11-year-old child presents with bleeding gums, EC, bruising and irritability. X-ray shows pencil thin cortex. What is the probable problem? Where do you see pencil thin cortex? Which condition? Scurvy, very good. It is seen in scurvy. Very good. It is seen in scurvy. And scurvy is nothing but vitamin C deficiency. Okay, that is our answer. So this is a slide that you need to learn by heart. Very, very important slide that gives you the X-ray changes in scurvy. Okay. Changes can occur in the diaphysis, metaphysis, and epiphysis. In the diaphysis, the first change you see is osteopenia. Then you can have ground glass appearance, pencil thin cortex or subperiosteal hemorrhage. Of this, so pencil thin cortex is what is very, very important. In the metaphysis, you can sometimes see a whitish line like this, which is called the white line of Frankel or Frankel's white line. And immediately adjacent to the Frankel's white line, you can see a clear area here. Can you see that clear area? That is called the scorbutic zone or the Trummerfeld zone. Sometimes the white line of Frankel can extend beyond the borders like this and form spikes, small spikes extending outside the metaphysis. This is what we call as Pelken spurs. In the epiphysis, you can see a ring-shaped epiphysis with surrounding sclerosis. This is called Wimberger sign. Okay. So even if you don't know the various explanations, at least know the names. Okay. Frankel's white line, Trummerfeld zone, Pelken spur, and Wimberger sign. Remember that all of these are seen in vitamin C deficiency or ricket or scurvy. Now, can anyone tell me which other condition can produce Frankel's white line? Which other condition can produce Frankel's white line? So, Sudhi, you are half correct. You are saying rickets, you are halfway there, half correct. This healing rickets. Okay, healing rickets. It can also be seen in healing rickets, where a patient has rickets and you start them on vitamin D, and after about 1 month or 2 months, you take an X-ray, you will see the white line of Frankel. That is your healing rickets. Healing rickets can also produce white line of Frankel. All right. This is a very important slide. Please learn this by heart. Okay. Next question. Which is the biochemical change seen in osteoporosis? Can you tell me the answer? It's a slightly tricky question. I think people are confused between A and D. Yeah, you're right. It came in INICT and it has also come in NEET several years back. That is why I'm asking you. Because it is a very simple question, but People may find it difficult to answer. Normal, very good, very good. Everything will be normal in osteoporosis. Okay. Osteoporosis, remember, has no biochemical abnormality. No biochemical abnormality. Okay. Osteoporosis is diagnosed not by blood test, but by using DEXA scan. Okay. Using DEXA scan, you can get something known as a T score. And if the T score is less than minus 2.5, okay, then you call it osteoporosis. You cannot diagnose osteoporosis by a blood test. Okay, that is the importance here. There is no blood change in osteoporosis. Blood is absolutely normal. Very, very important point. Okay, this is also important MCQ. The investigation of choice for osteoporosis is a DEXA scan. And in DEXA scan, you get T score, and T score less than minus 2.5 is the definition of osteoporosis. All right. Again, a previous year question for you. A 6-year-old child brought to the OPD with difficulty in shoulder abduction. On examination, he has deformity of the back as shown in the picture. What is the diagnosis? What is the problem here? The child has a problem in the shoulder. So I think you must focus on the shoulder. Okay. And not on the neck. People are confused between Klippel-Feil syndrome and Sprengel shoulder here. So if you look here, you will see that the scapula here is at a higher level than the opposite side, isn't it? The scapula is undescended. So you have a congenital undescended scapula, which is called what? It is called Sprengel shoulder. Sprengel shoulder. Okay. Sprengel shoulder. That is the answer here. So what happens is that you have the cervical spine here, the scapula there. There is an abnormal connection between the scapula and the cervical spine, which is called the omovertebral bone. And this omovertebral bone will prevent the normal descent of the scapula. Normally, the scapulae are formed near the cervical region, and slowly over the period of embryogenesis, it comes downwards. Okay. So, because of the omovertebral bone, the normal descent of the scapula doesn't take place, and one scapula will be a higher level and other will be at a lower level. Yes, Mupin, it's almost like Pushpa. Yeah. So that is your Sprengel shoulder. Okay, this is your Sprengel shoulder. People are asking what about Klippel-Feil syndrome. That is why I have kept Klippel-Feil syndrome as the next picture. You can clearly see the difference, isn't it? So in Klippel-Feil syndrome, the problem is in the neck. Here in the question itself, they have mentioned that the problem is in shoulder abduction. So then there itself, you should think that the problem is not at the neck, but at the shoulder. So you'll have to think about the scapula. Okay. So what is Klippel-Feil syndrome? You have three things. What are they? First, there is a short neck. Secondly, there is a low hairline and there is a stiff neck. What happens here is that there is formation of fused vertebrae. Fused vertebrae. Multiple vertebrae are fused together. So the vertebra will be, or the neck will be short and the hairline will be low. And because of the fusion between the vertebrae, the movement between the vertebrae don't take place. So what will happen? The neck will become stiff. Neck movements will be completely restricted. So this is the classical finding of Klippel-Feil syndrome. So please do not get confused between Klippel-Feil syndrome and your Sprengel shoulder. Next question. A 55-year-old lady presented to the OPD with complaints of polyarthralgia for 10 years. She has developed deformities of hands over the last 2 years, as shown in the image. What is the most probable diagnosis? What is it? Easy, right? What is the answer? What are the changes you see? You will see that all the fingers are bent in one direction, isn't it? It is bent in the medial direction or ulnar direction. So there is an ulnar drift of fingers. Ulnar drift of fingers at the MCP joint. What else do you see? You can see that the thumbs are in the shape of an Z, isn't it? An Z deformity of the thumb. And both these are seen in which condition? Rheumatoid arthritis. Rheumatoid arthritis. That is our answer. So hand changes in rheumatoid arthritis are very, very important. You need to learn this by heart. First and the earliest change we have already discussed is the ulnar drift of the metacarpophalangeal joints. Then swan neck deformity, we have already learned that where there is an hyperextension of PIP and flexion of the DIP joint. Then you have your boutonniere deformity, where you have the reverse of swan neck, where there's flexion of PIP and extension at the DIP joint. Then you have Z deformity of thumb and something called hitchhiker's thumb, where the thumb will be extended like this. Okay, that is hitchhiker's thumb. Ulnar drift of fingers, swan neck deformity, boutonniere deformity, hitchhiker's thumb, and Z deformity of thumb. The classical 5 findings in rheumatoid arthritis. Okay. Next question. A 54-year-old man presents with history of RTA. He has sustained fracture as shown in the X-ray below. Which nerve can be injured in association with this fracture? Can you tell me? Which joint is this? This is the knee joint. This is the femur. This is the tibia. This is the fibula. And there is a fracture here. There is a fracture of the neck of fibula. And there is a nerve that comes like this, isn't it? Very close to the neck of fibula. What nerve is that? That is the common perennial nerve. Very good. Ishwar, Arafat, Ginny, Mupin. Absolutely right. All of you are absolutely correct. This is your common perennial nerve. So whenever you have a fracture of the neck of the fibula, you will have injury to the common perennial nerve. And what happens? What is the deformity that you get in common perennial nerve injury? Very good, Ginny. Absolutely correct. This is your foot drop. You get your foot drop. And what is the abnormal gait that you get whenever there is foot drop? What is the abnormal gait that you get? High stepping gait. Absolutely correct. You get the high stepping gait. Okay. So you have foot drop and high stepping gait. So this is what I said. You have the common perennial nerve winding around the neck of fibula like this. So whenever there is a fracture there, you get a high chance of CPN injury. And what splint is this? This is your simple foot drop splint. Used whenever there is a foot drop. Okay. So that is your foot drop and foot drop splint. So this is a very, very important question. Either they could give you an X-ray or they can ask a clinical vignette around this. So shall we go to the next question? A 50-year-old male had attended a wedding in which he consumed alcohol and meat yesterday. Today he presents to you with severe pain in his right big toe. Aspiration of first MTB joint shows negatively birefringent needle-shaped crystals. What is the diagnosis? Again, we are dealing with the crystal arthropathy, isn't it? Because crystals are there. We have already discussed the two scenarios. What do you think this is? This is a middle-aged man. There is a trigger, isn't it? He consumed alcohol and meat. This is a trigger for which condition? Gout. Yes, very good. There is a gout. And the pain is in the right big toe, which is the most common joint involved in gout. And aspiration shows negatively birefringent needle-shaped crystals, which is MSU crystals, which are seen in gout. This is a classical presentation of gout. So we learned about pseudo gout as well as gout. Okay. Next, simple question. What is the most abundant protein seen in bone? Yes, very good, very good. It is type 1 collagen, isn't it? That is why we get osteogenesis imperfecta, because there collagen type 1 is deficient or abnormal. That is why you get that is why bone is so much affected in osteogenesis imperfecta. So you can remember it like this. Bone has 1 in it, isn't it? Bone has 1 in it. So this type 1 collagen, which is the most abundant protein seen in bone. Next, which is not a feature of osteoclast? What do you think is not a feature of osteoclast? Does it resorb bone? Yes, it resorbs bone. It is multinucleated. That is also correct. It rests in Auschwitz raccoon. That is correct. Very good. Prince, Abra, Ishwar, absolutely correct. You are correct. This is the answer. It produces alkaline phosphatase. That is not correct. Osteoclast produces TRAP. which is tartrate resistant acid phosphatase. Alkaline phosphatase is actually produced by osteoblasts. Okay, osteoblasts and not osteoclasts. So remember, osteoclast is a multinucleated cell which is formed by fusion of multiple monocytes. So it will have multiple nuclei, and one border will have finger-like projections like this, which is called the ruffled borders. And when you take a histology slide, you will see that it rests in a small depression like this, which is called Hauschup's lacunae, and it produces tartrate-resistant acid phosphatase and not alkaline phosphatase. Alkaline phosphatase is produced by your osteoblast, which is the bone-forming cell of your body. Okay, next question. A 7-year-old child presents with swelling of her right thigh for the last 2 months. X-ray shows a tumor arising from the diaphysis of the femur. Biopsy shows round blue cells which are MYC2 positive. What is the diagnosis? Now we have already discussed the differences between various tumors. Now you have to tell me the answer. Look at the age of the child. What did I tell you when we discussed simple bone cyst? What are the two tumors that can occur in a child less than 10 years? Simple bone cyst and Ewing sarcoma, isn't it? Ewing sarcoma. And simple bone cyst will occur where? Will occur in the metaphysis, and Ewing's will occur in the diaphysis. So just by looking at the first sentence or first two sentences, you will know the answer. But again, when you are given the biopsy, that will give you confirmation. Biopsy will show round blue cells which are MYC2 positive. This is a very, very important point. Okay. MYC2 positivity is an important finding in Ewing sarcoma. MYC2 positivity. Okay. So our answer is Ewing sarcoma. So always remember that the most common bone involved in Ewing sarcoma is your femur. The age is between 5 to 15 years, but most commonly before 10 years. Okay. Most commonly it is seen before 10 years. Site is a diaphysis, and it produces a classical periosteal reaction like this. What periosteal reaction is this? Can you tell me? It is the onion peel periosteal reaction. Correct. This is the onion peel periosteal reaction. Okay. What is the periosteal reaction that you see in osteosarcoma? You can either see a Codman's triangle or a sunburst appearance. So this is the biopsy finding. If you take a biopsy, you will see that there will be sheets of round blue cells. Everywhere there will be sheets of round blue cells, and intermittently there will be small areas of necrosis called pseudorhizomatosis. The important thing is that these blue cells will be MYC2 positive. And MYC2 is also called CD99. This finding is not seen in any other tumors. MYC2 positivity. That could be asked as an MCQ. Okay, MYC2 positivity. Please remember. And can you tell me the genetic mutation which is responsible for Ewing sarcoma? Again, a very important question. Usually asked as a part of pathology. Can you tell me the genetic mutation responsible for Ewing sarcoma? Oh, it is translocation. Translocation 1122. So remember, Ewing sarcoma 11. E for Ewing's, E for 11. Translocation 11 and double its number 1122. Okay. Translocation 1122. It has been asked as part of pathology as well as part of orthopedics. Okay. Important. Next question. Which is the most dangerous type of odontoid fracture according to the Anderson-D'Alonso classification? What is the answer? Very good. Prince Ishwar, absolutely correct. This is Abra, you're also correct. This is type 2. Type 2. Okay. So, what is this odontoid? Odontoid is nothing but the dense process. Dense process of which vertebra? C1 or C2? Dense process of axis or atlas? Of axis. Of C2. Okay. So, you have dense process fractures. Yeah, correct, Prince. Absolutely correct. So even if you don't remember the name, it is okay, but you need to know the classification. Just I'll tell you very simply what this is. Type 1 is a fracture in the tip of the dense process. Type 2 along the base and type 3 along the body like this. Why is this important? So I'll draw a picture and show you why this is important. Okay. So you have a dense like this. You have lots of blood vessels coming in like this. Okay, so blood vessels are coming in like this, but you can see that this area has no blood supply or the blood supply is very low. This kind of area is what is called as a watershed area. This is a watershed area. Okay, watershed area is a area between blood supply regions where the blood supply is very less. So in type 1, there is a fracture here. No problem, it will unite. Type 3, there is a fracture here. There is no problem, it will unite because lots of blood supply is there. But what happens if you have a fracture here? Will it unite? Will it unite? No. Why? Because it is a watershed area, blood supply is very low, will not unite and it will undergo non-union. And what happens when there is a non-union? There will be a mobility there. It will move and it will press against the cervical spinal cord, and what will happen? The patient will develop quadriplegia. That is why it is a very, very dangerous complication. Okay. So type 2, we are all scared. Type 1, type 2, we put cervical collar and send the patient home. Type 2 is very dangerous. We have to have a spine surgeon or a neurosurgeon and we have to fix the type 2 fracture using a screw. So always remember, type 2 has a high risk of non-union, which can cause cervical cord injury and quadriparesis. So remember, type 2 odontoid fractures are the most dangerous type. Okay. Understood? Can we move on? All right. Now, this is a very, very easy question. Which fracture malunion causes the dinner fork deformity? Yes. Very good. Parikshit, Arun, absolutely correct. What is this? Prince, correct. This is Foley's fracture, isn't it? Foley's fracture produces the dinner fork deformity. So this is the dinner fork deformity. In Foley's fracture, you have a fracture occurring at the corticocancerous junction of the distal radius. And because of the fracture, there is a dorsal displacement of the distal fragment here. There is a dorsal displacement like this. Dorsal displacement. And because of that, you get this beautiful dinner fork kind of deformity there. Okay. Foley's fracture is a very important fracture. Other questions can also come from it. Abra is saying it is seen in elderly postmenopausal women. You are absolutely correct. Treatment-wise, Foley's fracture is treated using slabs below elbow cast, which is called the Foley's cast or the handshake cast. Another important MCQ is the position in which Foley's cast is given. Remember, it is given in palmar flexion and ulnar deviation. Palmar flexion, ulnar deviation. Always remember this. Okay. Foley's cast is in palmar flexion, ulnar deviation, and the thumb is free. If the thumb also has plaster, it is scaphoid cast. Okay. If the thumb does not have any cast, then it is Foley's cast. Remember. Abra is asking if there is fixation needed. Usually, no. Foley's fracture don't require fixation. We only treat it conservatively by putting plasters. Okay. Remember that these patients are usually 75, 80-year-old lady. Why do you want to subject them to unnecessary surgeries and all? Many of them will have heart diseases and all. We usually do not do surgery for them. Even if the Foley's fracture malunites a little bit, nothing is going to happen. The patient will have 100% function. Okay. What does an 80-year-old do? She is going to take weights and all? No. She is going to do her own activities. She will have to brush the teeth, have food, comb the hair, take bath, do small things in the kitchen. For all those purposes, a malunited Foley's fracture is enough. So you don't have to do a surgery at all. Okay. What is this? This is the opposite of Foley's fracture. What fracture is this, or what deformity is this? Can you tell me? Yes, very good. The picture shows the what deformity? Garden spade deformity, isn't it? This is the garden spade deformity. And here you see it in which fracture? Smith fracture. Smith fracture is a reverse Colles fracture. Reverse Colles fracture. In reverse Colles fracture, again, you get a fracture of the distal part of the radius, but instead of having a dorsal displacement, you have a ventral or a volar displacement. Okay, that is why you get the classical garden spade deformity. This is a very important MCQ. Okay. Next question, another triad. This is not part of the terrible triad of knee. Can you tell me the answer? This is very good, very good. I think a lot of you have got this correct. Abra, Prince, Ginny, Ishwar, Arun, all of you are right. It is PCL tear. In terrible triad of knee, remember that the injury is on the medial side. Terrible triad of the knee, injury is on the medial side. So you have an injury to the MCL, then the medial meniscus and the ACL. Okay. PCL is completely intact. The injury goes like this. So you have an MCL, medial meniscus, and an ACL tear. There is no PCL tear in terrible triad of the knee. Next question. A 70-year-old lady presents with fractured neck of femur after a fall. What is the ideal treatment for this lady? How do you treat fractured neck of femur in an elderly patient? Very easy question, isn't it? Can you put a plaster? Hip spica? No. Skin traction? No. Intramedullary nailing? No. What is the treatment? Arafat, you are absolutely correct. Garima, absolutely correct. This is hemiarthroplasty. Hemiarthroplasty. Safa, you are also absolutely correct. Hemiarthroplasty. Now, what is this hemiarthroplasty? So, I'll draw a picture and show you. This is your femur, and there is a fracture in the neck of femur like this. Okay. So, in an elderly patient, fractured neck of femur will never unite. Whatever you do in an elderly patient, the fracture is not going to unite. So, there is no point in keeping the femoral head there because the femoral head will not unite and it will undergo a vascular necrosis. So, what we do is that we will completely excise the femoral head. We will cut and take the femoral head out and we replace the femoral head using a prosthesis like this, a metal implant. So this is the acetabulum. This is what we call as the hemiarthroplasty. Hemiarthroplasty. So Acharya is asked, what about total hip replacement? In total hip replacement, you do a hemiarthroplasty and you replace the acetabulum also with a artificial cup like this. Okay, that is done in younger patient with certain hip disease such as hip osteoarthritis or avascular necrosis of the femoral head. In all those conditions, when the femoral head is completely destroyed in a younger patient, we can do a total hip replacement. For our patient, we don't need that because this is an elderly patient. They require only a hemiarthroplasty. Okay. Next question. A 25-year-old woman delivers a baby by normal vaginal birth. However, she develops pain and paresthesia over the anterolateral aspect of her right thigh. Which nerve is probably injured? Can you tell me the answer? Which nerve injury in normal vaginal delivery? Very good, very good. Yes, Ginny, Garima, Neha, absolutely correct. Arun, absolutely correct. The answer is lateral femoral cutaneous nerve. Lateral femoral cutaneous nerve. I thought this question would be difficult, but I think most of you have got this correct. Lateral femoral cutaneous nerve. So what happens is that we have something called as the lateral femoral cutaneous nerve, which starts in the lumbar plexus here, comes down and goes under the inguinal canal here, comes down and supplies the anterolateral part of the thigh. Okay. And in the normal vaginal delivery, what happens is that the mother has to flex the hip like this. Okay. She has to keep the hip like this for a long time, especially if the Mac-Roberts maneuver has been done. Okay. So if that is being done, the hip has to be flexed for a long time and the nerve will get kinked here under the inguinal ligament and there will be injury. And this kind of injury is called as meralgia paresthetica. This is also an MCQ for you. Okay. So an injury to the lateral femoral cutaneous nerve is called meralgia paresthetica. And remember that lateral femoral cutaneous nerve is also called by another name, lateral cutaneous nerve of thigh. Okay. Both are just the same, also known as. Okay. So remember that lateral femoral cutaneous nerve and lateral cutaneous nerve of thigh are absolutely same. And when the nerve is compressed, you get meralgia paresthetica. One of the most important causes, vaginal birth. Okay. Manish Dubey, which is the right answer in the last question, it is hemiarthroplasty. Okay. 58th question, it is hemiarthroplasty. Elderly patient with neck of femur, we have to do a hemiarthroplasty. Okay. Next question. Identify the brace shown. Previous year question. What is the answer? All braces are very important. Yeah, that is why I thought that there would be confusion between Taylor's brace and Milwaukee brace. That is why I put this question. Both has been asked previously. Remember that Milwaukee brace reaches the neck of the patient. Can you see? The brace is reaching till the neck. There is no other brace in orthopedics that extends till the neck of a patient. Okay, please remember that no brace in orthopedics reaches the neck of the patient except Milwaukee brace. Milwaukee brace. Okay, so if the brace is reaching the neck of the patient, it is Milwaukee brace. Where do you use this? What is the indication for using Milwaukee brace? For which condition do we use it? We use it for scoliosis, isn't it? We use it for scoliosis. Yes, correct. Parikshit, Garima, absolutely correct. We use it for scoliosis. There are three braces that we use for scoliosis. One is Milwaukee brace, which reaches till the neck. Why? Because we use Milwaukee brace for high level scoliosis, where the scoliosis apex is above the T7. T7 is thoracic vertebra 7. If it is above T7, then we'll have to extend the brace till the neck. That is why we use the Milwaukee brace. In Boston's brace, we can use for a low level scoliosis where the apex is below T7 level. Okay. Here, the neck does not have to be included. It starts from the thoracic level and goes downwards. And then we have something called Charleston bending brace, which is a brace which is made up of soft plastic, which the child can wear and sleep during night. Remember that all these scoliosis and all are very commonly seen in young females, usually around 12, 13, 14 years of age. So they may not tolerate putting these braces and sleeping at night. So for that, we change the brace to Charleston's bending brace during night. Of all these braces, please remember Milwaukee brace, which is most important. Okay, Boston brace and Charleston are also important. You don't have to go into the details, at least know the names. Next question. Which fracture can cause the deformity shown in the image below? Previous year question, recently asked. What is the answer? What deformity is this? Abra is correct. This is gunstock deformity, but is it genu varum valgum, cubitus varus valgus, coxa vara valga? What is it? This cubitus varus deformity, which is seen in malunited supracondylar fractures. Okay. I know that many of you are very confused regarding deformities. Many of you have several codes and mnemonics for that, but I don't think all mnemonics work in all joints. So I think the best thing to do is to have a basic idea of how to identify any deformity that is given to you. Okay. So what I'll do is that I'll explain it to you in a very easy manner. So please listen to me carefully. Every year you get at least 1 or 2 questions from a deformity. So you have to know how to identify it. Okay. So let's start with this picture. Okay. So whenever you get a picture of a deformity, mark the distal part of the deformity. Please remember that you mark the distal part of the. Is there any issue? Is there any technical issue? Lag. Okay. Is it okay now? Is it okay? Shall we continue? Okay. Okay, I'll repeat this again. Okay. So, for identifying any deformity, the first thing you do is, there are 3 steps. The first thing you do is, you mark the midline of the body like this. Very easy. You mark the midline. Second thing you do is, you mark the point of deformity. Here, the point of deformity is the elbow. So, you mark that place. Then you mark the distal part of the deformity like this. Okay, distal part of the deformity. Now, is there any issue now? Is it all right? Okay. Good to go, no? Good to go? Yeah, okay. All right, all right. So, please completely ignore the proximal part. Please ignore the proximal part. Just focus on the distal part of the deformity, okay? So, here you don't have to look at the arm, just look at the forearm. See which direction the distal part is going. Is it going towards the midline or away from the midline? Here it is going towards the midline. So towards midline means it is varus. And away from midline is, then you call it valgus. Okay. If the distal part of the deformity is moving towards the midline, it is varus. If it is away, it is valgus. Okay. So we have varus and valgus. But that is not enough. Based on the joint, we have to add something. A prefix has to be given. So if the deformity is in the hand or the wrist, you have to call it a manus. Manus, varus, or valgus. In the elbow, you call it cubitus, varus, or valgus. Okay. In the hip, you call it coxa, varus, or valga. In the knee, you call it genu, varus, or valgum. Angle, we call it talipes. Foot, we call it pes, varus, valgus. Big toe, we call it hallux, varus, valgus. So let's see if we can identify few deformities. Can you look at the deformity and tell me what deformity is this? This one. I draw the midline here. I mark the point of deformity and I draw the distal part, which is the leg. Is it moving towards or away? It's moving towards. So it is genu varum. Genu varum. Genu because it is the knee. So genu varum is bilateral genu varum. Okay, got it? Next, let's look at this. Again, I draw a midline. Then I mark the point of deformity, which is the big toe. Then I mark the distal part of the deformity, which is the toe. Because it is the toe, you call it hallux. Now tell me, it is varus or valgus? It is going away from the midline. It is going away from the midline. So it is valgus. It is hallux valgus. Hallux valgus. Many of your grandmothers would have feet like this because of their old age. Hallux valgus, isn't it? Correct. Now let's look at this. Again, I draw a midline. The deformity is at the wrist or the hand. I draw the distal part like this. Now tell me what is this? Because it is the hand, we call it manus. And is it valgus or varus? Very good, Mupin. This is valgum. Understood? Okay. So please, today itself, you take some pictures of various deformities. You apply the same thing and you see if you can identify the deformities or not. This is very, very important. Okay. Unless you identify the deformity, it will be difficult for you to answer the questions correctly. Okay. It's a very simple concept. Don't go for any mnemonic and all. It is very confusing. If you learn this, you can apply to any joint in the body. Okay. Any joint in the body, deformity can be identified. Okay. Then varum and varus are same. Don't have to worry. Okay. Valgus, valgum are same. Okay. Next question. Again, there is a deformity coming here. A 70-year-old lady presents with complaints of pain in both knees for the last 5 years. She has difficulty climbing stairs, squatting, and walking long distances. Her clinical image is given. What is the probable diagnosis? What is the answer? Easy question, right? Isn't it? Many of our grandmothers would have the same complaints. They will complain that I have knee pain on both my knees. I cannot squat. I cannot walk properly. I cannot climb stairs. She may have the complaints for 5-6 years. And when you examine the knee would be like this, isn't it? First of all, tell me what is the deformity that you see here? Can you tell me the deformity that you see here? What is the deformity? Very good, very good. There is genu varum. There is genu varum bilaterally, isn't it? And always remember that the most common cause of genu varum in an adult is osteoarthritis. Most common causes osteoarthritis, and all the clinical features point towards osteoarthritis. Can it be rheumatoid arthritis? See, rheumatoid arthritis usually occurs in a younger female, 30 to 50 years, not 70 years. Okay, so it cannot be rheumatoid arthritis. Secondly, rheumatoid arthritis produces genu valgum. Remember that rheumatoid arthritis produces genu valgum. More commonly, okay. Osteoarthritis producers are genu varum. So unlikely that it is rheumatoid arthritis. Can it be ankylosing spondylosis? Can it be? No, why? Because it is a disease more commonly seen in males, young males, isn't it? 15 to 30, 35 years is where we see ankylosing spondylosis. There again, the spine is more commonly involved. Can it be post-traumatic deformity? The question does not say anything about trauma. Again, both the knees are equally affected. What trauma produces both knees equally affecting like that? That cannot happen, isn't it? So it cannot be a post-traumatic deformity. This is your straightforward osteoarthritis, isn't it? Any doubts here? Can clearly identify the diagnosis, isn't it? Here. Okay. Next question then. A 50-year-old manual laborer presented with sudden pain in his right arm while lifting a heavy load, followed by appearance of swelling in his arm. Clinical image is given. What is the answer? What sign is this? Can you tell me? I think very good, very good. I think almost all of you have got this correct, isn't it? This is the correct. This is the Popeye sign. This is the Popeye sign. Looks like the big muscles of the Popeye, isn't it? So this is your Popeye sign, and it is seen in biceps tendon rupture. Very good. All of you are absolutely correct. Okay. So what happens here is that when the patient lifts up a heavy weight, the tendon of the biceps will be ruptured. Always remember that biceps has two heads, isn't it? It has a long head and a short head. The short head attaches to the tip of the coracoid, and the long head goes inside the shoulder joint and attaches on the top of the glenoid. Okay, this is the long head. Or usually what happens is that the tendon of the long head will rupture, and all the fibers will get retracted downwards, and it will bunch up like this. Okay, it will bunch up like this, forming a ball like this. This is what is seen here. All the muscles from fibers from here has retracted downwards and has bunched up there. And this looks like the big muscle of Popeye. That is why it is called the Popeye sign. Popeye sign. By the way, how many of you have seen Popeye cartoon when they were children? A lot of people have seen. So this was, I mean, Popeye was released long back in 1950s and 1960s. We used to watch them when we were children in 1990s. Popeye the Sailor Man. Good that at least few of you know about him. When I take classes nowadays, when I say Popeye and all, people are like, Popeye. Oh my God, who is Popeye? I never heard about Popeye before. On Cartoon Network. Yeah. Good. So at least few of you people have seen it. That is nice. Okay. Yeah, early 2000 kids would also have seen it. Yeah, correct. Yeah. Anyway, let's move on. This is a previous year question, a little tricky question. That is why I've kept it here. Vinay is saying he's afraid to do biceps curls. There is nothing, don't worry, man. You can do biceps curls, no problem. Usually, this condition occurs whenever there is a pre-existing shoulder disorder. You don't have to go into it, but just know that you are safe, Vinay. You can go do your biceps curls without any problem. Okay. So, which is the most common site of origin of TB in hip joint? Give your answers based on your on the picture given here. What is the answer? Okay. First of all, what is this question about? See, whenever tuberculosis starts in a joint, it has to start at some point, isn't it? In the hip joint, it can start at 4 places. So these are the 4 sites that are marked here. It can either start at the roof of the acetabular. That is one. Then it can occur at the femoral head. Then it can occur at the greater trochanter. Then it can occur at a small triangular area in the inferior part of the neck, which is called the Babcock triangle. Babcock triangle. Okay. So these are the 4 places where you can get the starting of tuberculosis of infection in the hip joint. By far, the most common site is the roof of acetabulum. Okay. The roof of acetabulum is the most common site here. So site 1, that is our answer. So this is a previous year question. So very important. Okay. In which situation is the MES score used for? Can anyone tell me? What is MES score? MES is mangled extremity severity score. Okay. Usually, when a patient comes with a very serious accident, they will have open fractures and all severe injuries in the leg. Most of these fractures we treat by putting implants, either external fixation or internal fixation. Sometimes the patient's health and the patient's body or the affected limb will be completely crushed or mangled in such a way that we will not be able to repair it. In such a situation, we'll have to do amputation, isn't it? So, in order to identify whether a particular injury should be managed by fixation or should we go in for amputation, there is a score which is called the mangled extremity severity score. Okay, I think most of you have got it correct. Karthikeyan, Arafat, Garima, Ahmad, all of you are absolutely correct. This is to determine whether to do an amputation in a severe limb injury or not. Okay, so that is where we use mangled extremity severity score or MES score. Okay, MES score of more than 8. So Ashwin is asking what is the cutoff level. It is actually different papers say different. There is usually it is 7 or 8. Okay. Where I work, we usually use the cutoff as 8. If it is above 8, we have to do an amputation. Next question. A 24-year-old male after RTA with comes with fracture of the right femur 2 days back. He now develops difficulty in breathing and has aggressive behavior. On examination, there are rashes on the anterior abdominal wall. What is the diagnosis? Clear-cut question, isn't it? This is a previous year topic. Very, very important question. This is the classical presentation of fat embolism syndrome. Very good, very good. I think many of you have got this correct. Well done. This is the fat embolism syndrome. It is important not just for you for your exam, but as when you join your internship or whenever you are practicing, it is very important that you identify a fat embolism syndrome. Okay. I remember when I was doing my internship, I was on duty in the ward, and the sister in the ward called me that, doctor, come here, the patient who we had posted tomorrow for surgery, exactly the same thing as the question states. He is not behaving well. He is aggressive. He has pulled out all his cannulas. He was on catheter. He has pulled out his catheter. Come fast, do something. I go there and I see this patient. I look at the pulse oximeter. The oxygenation was around 95%. The pulse rate was around 120. He was completely disoriented. He was saying obscenities. He was not identifying that I was a doctor. He was not behaving well. I was also angry. Actually, at that time, I did not know what was happening. Okay. And I looked at the CT to see whether there was any head injury. There was no head injury. I asked the bystanders whether he was an alcoholic to see if there was alcohol withdrawal syndrome. No, there is no alcohol. So I was absolutely confused. I thought I'll give some diazepam for the patient so that he calms down and sleeps. Thankfully, I didn't do that. I was just standing there when thankfully my associate professor was walking down the corridor. Remember, this was 2 a.m. in the morning, and I don't know, for some reason he was there and he called me. Hey, come, Rohit, what happened? Why are you standing here? 2 a.m. in the morning, huh? Call, sir. And I said, sir, this patient is giving trouble. He is aggressive. He is shouting obscenities. And then he told me that, man, come, we'll check again. Then we connected the pulse oximeter and we slowly saw that the pulse dropped from 100. Slowly it came down and settled at around 75. And my associate professor told me that, see, this is fat embolism syndrome. We have to immediately shift the patient to an ICU and start him on a ventilator. And thankfully, because the associate professor was there, we shifted the patient to the ICU and we started him on ventilator. He was on ventilator for 7 days. And then that is when he recovered. So this is a very, very important situation for you. And always remember that there are a few important things you can always check. First, the trigger. There will always be a trigger. Usually there will be fracture shaft of femur. That is what 90% of the trigger will be. Sometimes burns can also cause this. Okay, but that is rare. Then there will always be a time delay of around 48 hours. Okay. Immediately after the fractured femur, this doesn't develop. Usually around 2 days time takes for the fat embolism syndrome to be there, to develop. So what happens here is that these fat globules from the bone marrow of the femur will enter into the fat circulation, enter into the CNS, into the respiratory system, and cause the organ damage there. There will be damage to the brain. That is why you get the CNS symptoms of aggressiveness and all. So there are 3 important triad of symptoms that you get. First is you get CNS symptoms in the form of aggressiveness, altered behavior, seizures, loss of consciousness, loss of memory, etc. Then you will have respiratory symptoms such as difficulty in breathing, tachypnea, reduced SpO2, and there will be rashes. Okay, rashes may be difficult to identify in our skin, skin complexion, isn't it? The other 2 features will be definitely there. There will be a respiratory depression and CNS symptoms will be there. Okay. So if any of these are there, you have to diagnose the condition. And there is a diagnostic criteria for this, which is called GERDS criteria. You don't have to learn the GERDS criteria at all. Just learn the name that it is GERDS criteria. Okay. Just learn the name that the criteria used for diagnosing fat embolism syndrome is GERDS criteria. That is all. Okay. All right. Next question. So this was asked in the INSCT question recently. So I thought this could be, usually questions like this don't come in NEET or in INSCT. So I thought it would be interesting for you as well. Never know. So can you tell me the answer? Hawkins classification used in which fractures? Very good, very good. At least few of you have got this correct. Absolutely. Oh, a lot of people have got this correct. Very good. So I thought this was going to be a difficult question. Have you guys gone through the INSIT paper recently? Yes, recall. Very good, very good, very good. That is why. Very good. So Hawkins classification is used for talus fractures. Okay. So anything related to Hawkins, there is something called Hawkins sign and Hawkins classification. Everything is related to talus fractures. Okay. So please remember this Hawkins classification and something called Hawkins sign. You don't have to worry about what Hawkins sign is. These are all related to talus fractures. So anything related to Hawkins is related to talus fractures. Just remember that. Okay. Don't have to go into the details at all. Next question. In which condition do you see the Rugger Jersey spine? This is a straightforward question, isn't it? It is seen in renal osteodystrophy. Renal osteodystrophy. What is this renal osteodystrophy? It is a destructive bone disease seen in which condition? Chronic renal failure. In chronic renal failure, there will be loss of calcium through the kidneys because kidneys are not functioning. Calcium will be lost, and all the calcium from the bones will be lost through urine. So what will happen? The bones will become very, very soft, and there will be severe bone pain, and there will be fractures. And in the spine, you get this classical appearance of alternating striations of white and black like this. Okay, this looks like the striations that you see in the jerseys which are worn by rugby players. That is why you call it the rugger jersey spine. Okay, these are the jerseys worn by your rugby players. That is why the name rugger jersey spine. You don't have to go into the details. Just know that renal osteodystrophy will produce rugger jersey spine. Next question. A 12-year-old child presented with injury to his right wrist after a fall. His X-ray is given below. Identify the type of physeal injury according to the Salter-Harris classification. Very, very important classification, Salter-Harris. Can you tell me? I think there is a little bit of confusion here. So let's look into what Salter-Harris classification is first. Okay. So what happens is that in a child, you have the bone and you have the physis. What is the physis? Physis is nothing but the growth plate. This is the most important part of a child's bone, growth plate. If the growth plate is injured, that bone is never going to grow again. Okay, so that is the danger of physeal injuries. Okay, now physeal injuries can occur in different patterns. There could be a fracture going like this. There could be a fracture going like this. There could be a fracture going like this. There could be fracture going like this, or there could be complete crushing of the physis. So depending upon the fracture types, there is a classification which is called the Salter-Harris classification. There are 5 types. Okay. In type 1, you can remember it using the mnemonic Salter itself. S is type 1, A is for type 2, L is for type 3, TE is for type 4, and R is for type 5. Type 1, what happens is that there is a injury at the level of the physis. So there is a small injury like this. Okay. This is what we call a separated or a fracture at the same level. Okay. S is for same level. There is an injury at the level of the physis. In type 2, there is a fracture that starts in the physis but goes above like this. A is for above. Fracture goes above. In type 3, fracture first starts like this and goes below. That is through the epiphysis. That is low. T is for through and through everything, where there is an injury that passes through the metaphysis, physis, and the epiphysis. In type 4, there is a rammed or complete destruction of the physis. Okay, this is type 1 to type 5. Now let's look at this fracture. There is a fracture line going above or below. It is going above, isn't it? So what type is this? What type is this? This is type 2. Yes, Ginny, Abhishek, Parikshit, absolutely correct. This is type 2 physeal injury. Type 2 physeal injury is what is usually asked. This is very, very important. Why? Because in the type 2 physeal injury, you will see that there is a triangular piece of bone here, isn't it? Can you tell me what is the name of this triangular piece of bone that is formed in type 2 physeal injury? It has a name. It is called the Thurston-Holland fracture. Thurston-Holland fragment. And the fracture is called Thurston-Holland fracture. This is the Thurston-Holland fragment. And if you look closely, the whole bone in this area looks like a boat, isn't it? And this area looks like a sail. So that is why it is called as a sail sign. Okay. So 2 important things in type 2 physeal injuries. Thurston-Holland fragment, which is this triangular piece of bone in the metaphysis, and sail sign on an X-ray, because that triangular piece will look like a sail. Okay, so 2 important MCQs in type 2 injuries. Okay. Next question. I think it is a straightforward question. A 35-year-old male gives history of falling asleep on a chair after drinking too much alcohol. On waking up, he noticed that he has weakness of the wrist. Clinical image is given here. What is the answer? What is the answer here? Straightforward question, isn't it? The patient has wrist drop. The patient has wrist drop. And what is the cause of wrist drop? Radial nerve injury, isn't it? This is a relatively easy question, isn't it? So whenever there is a wrist drop, the cause is radial nerve injury. And now what is the splint that we use for radial nerve injury? Can anyone tell me the splint, the name of the splint? Very good, very good. Cock-up splint, cock-up splint. Cock-up splint is also a very commonly asked MCQ. And the whole scenario is what we call as, yes, Arun, absolutely correct. This is called the Saturday night palsy. Saturday night palsy. When people enjoy the weekends, they go to a bar, drink too much alcohol, and sleep with a hand over the back rail like this. And this will press against the radial nerve and cause a radial nerve palsy. Okay, radial nerve, remember, it causes a wrist drop. The example is Saturday night palsy, and the splint used is cock-up splint. This is a previous year question. Which bursa is inflamed in housemate's knee? Can you tell me? Straightforward MCQ, isn't it? Abra, Garima, Stuti, Ginny, Abhishek, absolutely correct. All of you are absolutely correct. This is the prepatellar bursa that is inflamed in housemate's knee. So if you're asked which is the most common bursitis in the body, it is subacromial bursitis. Here, what is the sign that we get in subacromial bursitis? We learned that recently. What is that? What happens when you abduct the shoulder between 60 and 120 degrees? Subacromial bursitis. Yes, we get the painful arc syndrome, isn't it? Painful arc syndrome. So subacromial bursitis is the most common bursitis in humans, and it is one of the cause for painful arc syndrome. The other bursitis are given in this table, very important for your exam. Housemate's knee is prepatellar bursitis. Clergyman's knee is infrapatellar bursitis. Student's elbow is your olecranon bursitis. This occurs because when you write like this, you keep your olecranon on top of a bench and you write, then there will be compression of the olecranon bursa and you get olecranon bursitis. Then you have something called Haglund, which is associated with retrocalcaneal bursitis, and Weaver's bottom, where you have ischial bursitis. So these 5 MCQs you can learn for your exam. Okay. Next question. A 45-year-old plumber presents with pain in his left elbow for the last 5 months. On examination, there is tenderness over the lateral epicondyle of humerus. Cosen's test is positive. What is the probable diagnosis? What is this? Pain of the lateral epicondyle? Yes, very good. This is the classical tennis elbow, isn't it? Tennis elbow is lateral epicondylitis, where there is inflammation of the structures attached onto the lateral epicondyle. So you have the muscles, isn't it? The common extensor muscles, which are attached on the lateral epicondyle. So their origin area will also be inflamed. If you are asked which is the most common muscle to be involved in tennis elbow, the answer is extensor carpi radialis brevis. That is also an MCQ. Okay, the most common muscle involved is extensor carpi radialis brevis. Now, there are few tests that are very important for tennis elbow. One is your Cosen's test, where you ask the patient to dorsiflex the wrist and you apply a pressure. This will cause a pain in the lateral epicondyle. Second thing is your Maudsley test, where you ask the patient to dorsiflex the middle finger and you press the middle finger down against resistance. Okay. This will again cause pain in the lateral epicondyle. And third is your Mills test, where you straighten the elbow and ask the patient to, and you will palmar flex the wrist like this. This will again stress the common extensors and cause pain. Even if you don't remember the test, remember the names. Cosen's test, Maudsley test, and Mills test. 3 tests for your tennis elbow. Now, how do you treat your tennis elbow? This is a brace that we use for tennis elbow. Can you name the brace? Can you name the brace? This is the counter force brace. So counter force brace is used in tennis elbows. Okay. Next question. Which of the following injuries can result in regimental bad sign? What is regimental bad sign, first of all? Regimental bad sign is when there is paresthesias over the lateral aspect of the arm. That is your regimental bad sign. And this is seen in which condition? Axillary nerve injury. Axillary nerve injury. And what happens or what could be the cause of axillary nerve injury? Can anyone tell me out of this? Yes, Arun, Apa, all of you are absolutely correct. Axillary nerve injury occurs and it usually occurs in fracture neck of humerus, isn't it? Why? Because you have the humerus like this and the axillary nerve will wind around the neck of humerus. So if you have a fracture at the neck of humerus, obviously the axillary nerve will get injured and you get regimental bad sign. Now, why do you call it a regimental bad sign? Because this area is where the badge with the regiment's name is kept on army uniforms. Okay, like this. So that is why you call the anesthesia or paresthesia here as the regimental bad sign. So remember, regimental bad sign is associated with axillary nerve injury. It is seen in fracture neck of humerus as well as in which other dislocation? Can anyone tell me which dislocation can cause the axillary nerve injury? Yes, shoulder dislocation. Shoulder dislocation can again cause stretching of the axillary nerve and the same symptoms. Okay, as Arun Sai said, along with the nerve injury, whenever there is axillary nerve injury, obviously there is going to be an anesthesia. Along with that, there is going to be a weakness of the deltoid muscle also. So the patient will have difficulty abducting the shoulder. That is also there. Next question. In which condition is the splint shown in the image used for? Again, a very easy question, isn't it? This splint is called the, what is this splint called? Aeroplane splint, isn't it? This is the aeroplane splint, which is classically used in Erb's palsy. What is the deformity that you see in Erb's palsy? The policeman tip. Policeman tip or the waiter's tip deformity. Okay. Now, there are a few more splints that are important for you. One is your shoulder abduction splint, which can be given in axillary nerve injury. Axillary nerve injury, you can give the shoulder abduction splint. Philadelphia collar, again, can be asked as a question for you. It is used for neck injuries. Okay, Philadelphia collar. Then, whenever there is a median nerve injury, you can give an opponent splint. Opponent splint for median nerve injury. And the patient will have a ape thumb deformity. In that condition, we can give an opponent splint. This is a Koch-up splint, which is used for radial nerve injury. And foot drop splint, again, is for foot drop seen in common peroneal nerve injury. So this is a Taylor's brace, which was also asked as a previous year question. Remember that Taylor's brace never reaches the neck. If it reaches the neck, it is Milwaukee brace and not Taylor's brace. Okay. Taylor's brace is used for minor vertebral fractures. Then you have something called as the Ash brace or the anterior spinal hyperextension brace, where you put a brace in the front for an injury to the back. Why? Because there are certain spine injuries where the patient is not supposed to bend forwards like this. Okay. In order to prevent the patient from bending forward, you put the Ash brace so that the spine is kept erect like this and there is no aggravation of injury. That is your Ash brace. Next question, again a previous year question. Which is the commonest type of TB spine? Yes, very good. Paradiscal type. Paradiscal type, isn't it? There are 4 types of TB in the spine. One is your paradiscal type, which is the most common, where the disc and the adjacent part of the vertebrae are involved. Then you have the central type, where the central part of the vertebra is involved, anterior type where the anterior part of the vertebra is involved, and posterior type where the posterior elements such as the spinous processes, the facet joints, the pedicles, etc. are involved in the posterior type. The most common, remember, is the paradiscal type. Okay. Oh, so that was our last question. So that, so are there any questions? Okay. So all the best for your upcoming exam. So the session, the questions we have already discussed, but if there are any doubts, I'll wait for 5-10 minutes, no problem. If you have any doubts, please ask me now. Okay. Please repeat question number 22. Let me just check. Okay. So what is the doubt there? Question number 22, the answer is pseudo gout. Pseudo gout. Okay. Okay. So I also have a Telegram group. I think almost 700 of you are already members. So if any one of you is not there, you can definitely join. There also we can solve your doubts. Okay, MTP means gout. Not MTP, it is first MTP joint. First MTP joint is the most common joint. Most common joint involved in gout. Okay. That is the importance of first MTP joint. First MTP joint means that the ball of the big toe. Okay. Okay. For tumors, you have the epiphyseal tumors, you have the metaphyseal tumors, and the diaphyseal tumors. Okay. So there is a large flowchart. I won't be able to go into the details. I'll simply explain the most commonly asked questions. Okay. So in the epiphysis, there can be two tumors. In a child, it is chondroblastoma. In an adult, it is GCT. Okay. In the metaphysis, there are lots of tumors. Almost all tumors arise from the metaphysis. The exceptions are what arises from the epiphysis and diaphysis. So before going into the metaphysis, I'll go into the diaphysis. Okay. In the diaphysis, again, there are two tumors. Okay. Both of them occur in children. And one is a malignant tumor. The malignant tumor arising from the diaphysis is your Ewing's sarcoma. And the benign tumor arising from it is the osteoid osteoma. Okay. So Ewing's, we have already discussed, it will be in a young child, usually less than 10 years of age. There will be classical onion peel periosteal reaction. Femur is the most common bone that is involved, and on biopsy, you get the MIG2 positivity. Benign, we have osteoid osteoma. We know how osteoid osteoma is. It appears as a small lytic area called nidus, which is surrounded by severe sclerosis like this, isn't it? While Ewing's sarcoma will appear like this as a lytic area with lots of onion peel periosteal reaction. That is your Ewing's sarcoma. In the metaphysis, the primary or the most important tumor that you have to recognize is osteosarcoma. Okay. In osteosarcoma, you have this Codman's triangle that can occur, or there could be sunburst appearance like this. There will be a large lytic lesion. Age of the patient will be usually between 10 to 20 years of age. Then we have osteochondroma. which I think is quite easy to diagnose. You have the uh, pedicle and the expanded end at the tip. Then what else? Then there will be simple bone cyst. Simple bone cyst will have a large cyst like this in the metaphyseal region and a small piece of bone inside it. That will be the simple bone cyst. Then what else? Fibrous dysplasia, it is difficult to identify if there is no shepherd crook deformity. So definitely for your exam, shepherd crook deformity will be there in the femur. If that is there, you can definitely make the diagnosis of fibrous dysplasia. Is there any other tumor that you want me to discuss? So marker for bone resorption is trap. Trap is the marker for bone resorption. Then there are certain telomerase products that are there, but that is not important. Trap, which is produced by your osteoclast, isn't it? Osteoclast. Osteoclast, when there is increased activity of osteoclast, there will be increased bone resorption and there will be increased trap production. Okay. How many questions from ortho? Usually around 8 to 10 questions will be there. 8 to 10 questions. Lab findings of vitamin D hyperparathyroidism. You mean primary hyperparathyroidism, where there is a tumor of the parathyroid? Stuti, is that what you want? Or are you asking about rickets? Rickets, okay. In rickets, oh, okay, that is also very important. Okay, in rickets, the blood changes that you see in rickets are: one, calcium will be low, alkaline phosphatase will be elevated, phosphate will be low, parathyroid hormone will be elevated. This is the basic thing. But remember that sometimes calcium can be normal as well. When in an advanced stage, when the compensatory mechanisms run in, there will be normalization of calcium. That is also, so calcium will be low, alkaline phosphatase high, phosphate low, PTH will be high. That is rickets. High yield topics. Okay, high yield topics. Let me see. So you have trauma, nerve injuries, then tumors, then what else? Deformities and metabolic bone disease. This much we will have to learn. Okay. So these are the 5 most important areas from where questions come. Are there any other questions? Doubts? Okay, then shall we wind up? Ashwin is asking how much amount of marks is considered good for this ortho exam. I think if you score anything about 60%, then I think it would be very good. I think 50-60%, if you are able to score above that, because it is a minor subject, I think you have done very well. Okay. I think 50% of the questions were from directly previous year topics. So you should be able to crack all those things if you have read at least last 3 years of questions. Okay. I'll send the PDF, don't worry. So this is my Telegram group. So you can join this group, no problem. So we have been discussing many MCQs for the last, I think, 2 months now. So you can join us. Every day we'll be discussing some MCQs. If you have any doubts also, you can ask those questions in the group. How many hours for ortho revision? I think there is 1 month left. No, I think you can spend 1 day. That is all. Not more than 1 day. And just before the exam, maybe 1 or 2 hours, you can quickly go through our workbook, or if you have made a set of notes, you can go through that. MCQs will there. No. I mean, what I have done is that I have covered all topics. If you read through all the topics that I have discussed, then obviously that would be enough. But are these MCQs enough? No, definitely those are not enough. You will have to, I mean, read more than that. Yeah. Topics, these are enough. Maybe you'll have to read the other metabolic diseases and whatever I've written here. Nerve injuries, tumors, deformities, metabolic bone diseases, and trauma. These 5 things you will have to read. These 5 things you will have to learn. Okay. So shall we wind up? Okay. All right then. Thanks for joining in. So all the best for all of you. So please don't worry. Don't take too much of tension. Be cool. Learn. I mean, there are only few days left. So make maximum uses of your time. Even if you are unable to read for a very long time in a particular day, don't worry. You can make up later. But make sure that most of the days you should be focused and you should have a clear-cut idea of how to make use of the time that is left. So if you don't have a timetable of your own, I suggest that you will have to make up a timetable to see that you are able to cover all the important topics that have to be covered in the next few days. Okay. So thank you. So all the best. So your T&D videos in doc tutorials. Yeah. Test and discussion in doc tutorials. That is also very good. So there are a lot of questions that have been discussed there. I think there will be very few questions that will be overlapping. I have made all these questions new for you guys. So you can go and look into those questions. There will be many more questions that we have not discussed so far that will be available in those discussions. Okay. So you can contact me anytime. Can you see me? Okay. So you can contact me on WhatsApp anytime if you have any doubts, or you can also join the group, and if you have anything to contribute or if you have any doubts, you can clear it there as well. So that's it then. All the best. So we'll see you sometime later. Okay.